Ladies and gentlemen, we're going to go ahead and start the meeting here. Commissioner Jim French is going to chair this meeting until which time Mr. Tipton joins us. Thank you.
Good morning, everybody. This is Commissioner French. I'm going to call this meeting of the Humboldt County Board of Health to order. It's Thursday, December 3rd, 9 a.m. And the first order of business is we'll go ahead and have a roll call. Mr. Mendiola, could I get you to go ahead and make a roll call, please?
Yes, sir. Commissioner Cherry.
Present.
Commissioner Bell.
I'm here.
Sheriff Allen.
Here.
Dr. Stringham.
I'm here too.
And Chair French, you're here, and I'll announce Mr. Tipton when he gets in. So
I'm here.
Oh, he's here now. So I'll let Ken, why don't you go ahead and take over? We just started it because I wasn't sure. I hadn't seen you in, so.
I was trying to get it on my phone and I couldn't get that one to go through, so I ran back for my iPad.
What?
So, okay, gee, we have our virtual meeting room set up too, huh?
Yeah, we do. If you'll notice there's 3 little monitors up front, and if somebody wanted to be in there, they could watch the whole thing from there's great big screens out to your right and left, and then there's each one of you have your own monitor at your seat so that you can watch any activity just like we are here today. So.
Okay, we've done our roll call. Do we have a flag?
We do, yes, sir. Get that started. Oh, wait a minute here.
Okay.
There
Please
it is.
join the pledge. I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all. Thank you. Item 3 is public comment. It's general public comment is designated for discussion only. Public has an opportunity to address the commission on any matter not appearing on this agenda. However, no action may be taken on the matter until the matter has been placed specifically on an agenda as an item on which action may be taken. So do we have any public comment at this time? Hearing no public comment, we'll move to item 4, which is our update from the public health officer, Dr. Stringham, and we'll go with you first.
Excellent. Good morning, everybody. This morning, I'd like to hyper-focus our attention on what I see as being the biggest single challenge that this board faces to bring coronavirus under control in our community. We're having some problems these days, and I think a lot of us have been doing a lot of brainstorming and thinking about various ways that we can more adequately address the problem and bring things under better control. The messages that we're delivering, I think, are largely information-based rather than based on what I see as being more of a context. And I wanted to start my comments by explaining that the fact that you hear a gunshot is less important than the context under which you hear it. If you hear this at a gun range, it means that people are having a nice time and enjoying themselves. And if you hear this from a neighboring apartment, it means something entirely different. Context in this case is even more important than what you hear, than the specifics, and in this case, the specifics of the message. What's more important is that we cause the dynamics and the context of that message to be better suited to the needs of our community, which I think in the end will actually be the better way for us to go. I want to explain a little bit about why I'd like to take this approach. Last time when we visited last week, in the 2 weeks immediately prior to our last meeting, we had approximately 100 new cases in that 2-week period. This was by far the largest influx of new cases that we had seen. Well, the problem at this point is that that number in the last 7 days has tripled. And what we're doing needs to be done in a better way. And in my opinion, the best way to do that is going to be to put this into context. Sounds like somebody needs to mute their mic. Thank you. So the number of cases that we have gone up very, very significantly, and I'm really worried about this. What context to me means is that in the past, we've primarily given people information. And at this point, what I think we need to do is probably do a better job of actually helping people to put that information into context for themselves. To me, context is not only the way that we deliver the message, the specific means, the method that our community uses to deliver the message to community members, but in addition, it's also the applicability and the ways that people can use things. So far, I think we've primarily engaged in what people can't do. And at this point, I'd like to engage in what people can do. The other issue is that perhaps it's more important to determine the best ways to do things than it is whether or not those things should happen in the first place. I think a lot of the issues that we're combating at the county member level are things that are likely going to happen. And maybe if we change our approach to designing ways that people can more safely do the things that they seem to be doing in any case, we may meet with better success. The other issue with context is that so far we've primarily looked at issues with methods of delivery of information. And so far, a lot of what we've done has been social media based. It's been based on radio spots and various other things. But the two factors that I think make that a relatively dry approach is, number one, by the time the information reaches old news. And the second is it's not easily customizable. And I think to most of us, the information that we are going to apply, the situations that are specific to what we're doing, probably matters more to us. Answering questions in real times, having the ability to meet with people and to be able to discuss their specific questions. A lot of people have yet to buy into the whole concept that the virus is dangerous. And these need to be addressed. These are ways that we can absolutely bolster what we're doing and meet the demands. So it's not an easy thing to do, but I want to discuss some of the ways I think we can do that. And I'm very anxious to get some of the other board members and the community members' inputs on ways to best accomplish what we need to. I envision this happening in either a mass Zoom type of a system, or in other ways, a method that we can use that we can address people in real time during live presentations. I've always enjoyed the presentations that I give before the health board. And I think in general, what I'd enjoy more is being able to do these same types of forums, but for the entire community. I'm not tech savvy enough to know the best way to do that, but I do know that in general, I tend to respond best to a person who I can ask in real time, a person who I see as being knowledgeable in an area, and a person I can trust. From the very earliest phases of this virus, we have been combating an overabundance of conflicting information, and I think that if we can just get a continuous voice, and I'm happy to deliver that message. And I think just like with the gunshot, what's less important is the content of the message, and what's perhaps more important is the specific way in which that's done, to be something that is highly interactive with community members. Any questions they want to ask, any suggestions, recommendations, all in real time and all done live, I think would be wonderful. So I'd like to get some assistance with that from people who have more expertise than that than I do. Next, I'd like to move on to the design of the meeting. It's a little bit different today. So a lot of the things that I've shared with you in the past are now going to be shared specifically with the people who are more proximate to the information. And Humboldt County School District will be giving a presentation this morning. And in addition, the Humboldt General Hospital, which has always given presentations, but it'll be a more complete presentation this morning directly from officials at Humboldt General Hospital. And they can address some of the things that we've addressed previously. And I very much appreciate the fact that they're here and are going to be able to deliver more approximate information than I can. Not sure if this is on anybody else's mind also, but yesterday, CDC, Centers for Disease Control and Prevention, issued an update on recommendations that they're making for certain quarantining procedures. And I want to make some comments on that and let you know what I think and what the posture for Humboldt County should be. I'm concerned, and in keeping with the theme this morning of context, I'd like to first explain that the real issue in this case is that context is everything when CDC makes recommendations. And the CDC's recommendations are that we take a 14-day quarantining window and change that. So in the past, we've used 14 days as the period of time that quarantines are required for those people who've been exposed to the virus. They don't yet have viral symptoms, but they've been exposed. So in the past, we've used a 14-day quarantine phase for those folks. At the end of 14 days, they have not developed any symptoms, then they're released from quarantine at the end on the 14th day. So CDC is now recommending that we modify that in one of two alternative ways. Either number one, we can narrow that down to a 10-day quarantining phase and not use any testing for that. So no test is required. Quarantine for 10 days if you've been exposed to somebody who has the virus, and then you can be released from your quarantine. And the second candidate quarantining technique is a 7-day quarantine, but then at some point during the last 48 hours of that 7 days, you have to be tested, and that test has to be negative, return negative before the time that you're released from the 7-day quarantine. I'd like to preface my comments by saying that I have the utmost respect for CDC, and I found them to be a wonderful agency that gives great information, and they've provided wonderful leadership during the COVID crisis. But I do not agree with the recommendations that are being made, and the reason is context. The number of cases that we've had in Humboldt County has tripled in the last 7 days. Across the United States, we have almost 105,000 hospitalized patients, the largest that we've had so far. We have hospitals in various other municipalities that are being overwhelmed. We have a healthcare system that's having a lot of trouble. And in that context, CDC is making these recommendations. What I haven't told you yet is that with a 10-day quarantine phase, there's a 1% chance that a person may be released and still be infectious. CDC admits that, and they realize and they see that as being a shortcoming in the system. But when you release people at 7 days with tests, and those tests are negative, there's a 5% probability that a person will still be infectious. My concern is that not all people who are infected infect other people equally. In fact, 7% of those who are infected don't go on to infect any other people at all. But 30% of people make up for the difference. 30% of people do almost 100% of the subsequent infections. These definitely include super spreaders, but standard spreaders as well. And when you look at this and say, if we're releasing people who have only a 5% chance of infecting other people, but if they happen to belong to that 30% of people who will go on to infect many other people, then we're doing a really bad thing. If you're looking to save money on seatbelts and you live in a culture where the average driver travels at 25 miles an hour, I think it's pretty safe to save money on seatbelts. When you live in a culture where people are driving 80 miles an hour, it is a reckless idea to try to save money by going with a cheaper and less effective seatbelt. Happy to talk about this, but that's kind of the way that I'm feeling about this. I'd also like to point out that CDC has made several other recommendations, including one approximately 6 to 8 weeks ago, where the CDC came forward and decided that it was no longer necessary to test people who were exposed to people who were known to be positive. Here in Humboldt County, we decided that that was not a very wise thing to do, and within 2 weeks, CDC had changed their recommendations. This is part of the problem. We're making recommendations, and the recommendations are coming very quickly. In Humboldt County, my preference is to be moderate in our approach, to be steadfast, and to maintain a course in a certain direction and to maintain consistency, which is one of the issues that I hear a lot from our constituency, that people are finding that a lot of the information they're getting is not consistent. So I think it's important that we not adopt these new recommendations and instead wait and see what's going to wind up happening. I'd also like to point out that even though it's a 5% error rate, hospitals won't necessarily be overwhelmed by a 100% increase in patients. It only takes a few percent to do that when you have as many patients hospitalized as we do across the nation. So I think that this idea is not a very good one. I'd like to talk a little bit about FAST Team and brief you a little bit about what's going on there. Mr. Mendiola and I have spoken about some leadership on the FAST Team and to structure things a little bit differently. I'm very excited about the idea, and I've reached out to a person who we've tapped as a candidate to do this, and we'll be talking a little bit more today. But I think in the end, this person will be administrative in their role and not be a contact tracer at all, so that we can have our contact tracers be more dedicated to the job rather than having to work on administrative responsibilities. I think it's a wonderful thing. And we have several new team members. We have several others who are in the process of going through at this point, and very excited about that. The biggest single issue that we're seeing with the FAST Team, and one of the difficult parts, is that the number of team members that we have is not adequate for the circumstances. As I've said, the cases have tripled in the last 7 days, and but we're in the process of adding more people and a more effective management structure, which I'm really excited about. It's critical that community members answer the telephone when FAST Team members call. If you see a telephone number that you don't recognize, please answer that. In a lot of cases, people are giving telephone numbers at Humboldt General Hospital that then they subsequently are not answering those telephone calls that are coming to that number when our FAST Team members call. So please, if you don't recognize a number, try to do some research. And if it's better that you call the hospital and say, I'm being called, is that you? That would be a reasonable thing to do too. But please don't ignore those calls. In a lot of cases, FAST Team members are trying to make contact with folks. Time is of the essence, of course, and in many cases, people are not available. And finally, in terms of the kind of the heart of the matter issues, I'd like to talk a little bit about vaccination. During our last meeting, Sheriff Allen had brought up the point that if we had more information about vaccination, it might be a good thing, and I agreed. And so I prepared a very short presentation on the vaccinations, a little bit about how they work and time courses and various other things. I know that the Sheriff's Office has done a fantastic job with keeping infrastructure aspects of the vaccination. I'd like to talk a little bit about the technical aspects. So Pfizer BioNTech is really absolutely the front runner at this point. Moderna is going to have a vaccination out very, very quickly also, and both will likely be commercially available here over the next couple of weeks. On the 10th of this month, Pfizer is going to be appearing before the vaccination committee at the FDA, and it is possible that over the next several days after the 10th, that an authorization will be issued on this vaccination. I'm very excited about that. I can tell you that just yesterday, the United Kingdom had come forward with a new authorization on this exact vaccination. They have 40 million individual vaccinations, which will be enough for 20 million people. And that is literally starting. They're going to be vaccinating people on Tuesday. So this is real. We've been talking about this for a long time, but it's actually happening, and I'm very excited about this. I think we've got some great things that are going to happen. I'd like to talk to you a little bit about how these vaccinations fit in with behavior and with pre-existing plans, various other things that we've been talking about so far. And what I can tell you is that there are three different means by which we can acquire a herd type of an immunity. One of those is the people who've already been infected. And we don't know exactly what that number is. 14 million as of today is the known number. CDC has come forward and said that it is possible that there are 6 to 8 times more people who've actually been infected. And to be honest, I find that number very difficult to believe. My personal belief is that the actual number is probably somewhere between 14 and 20 million people. So it may be up to 10% of our population, but I don't think it's any higher than that. There will be vaccinations coming to Humboldt County very quickly for Tier 1 people. And I'm excited about that because while people who've been infected are very unlikely to become reinfected, and so by our calculations, somewhere in the neighborhood of 5 to 10% of the community has already been infected. But we can add to those people those folks who become vaccinated, because those people presumably will not be infectious or able to get the virus either. And so when we add those two numbers together, even after the first several weeks of vaccinations, we may pretty quickly hit 15 to 20% of the population that can no longer transmit this virus. And what that does is it moves the trees in the forest further apart, and it causes each individual tree to be less likely to burst into flames. So it's a wonderful strategy. I'm very excited about that. But the third and definitely the most critical component of our equation is we have to continue to do the right things. The reason is because it just means that that we become less flammable, but it does not mean that we become completely non-flammable. So it's critical that everybody continue to do the right things. Eventually, we can ease off on doing those right things once enough people are vaccinated that we gain a safety using a more convenient method. And that's really the beautiful part about the vaccination. So still going to require a lot of audience participation in the front parts of this, though. Moderna is going to be going through that same subcommittee on the 17th. And my best suspicion is that within about a week after that, we should have 2 commercially available vaccinations in the United States. Why have the British done this faster than we have? I can tell you that the FDA in general is very conservative. I think we really appreciate their approach to things. They're very interested in doing things safely, and they are not an agency that obstructs or delays. They are very much a safety-minded agency, and I'm very grateful that they're taking this approach. I want to talk a little bit about mRNA. You've heard that term undoubtedly. And what exactly is mRNA? How does it work? Is the vaccination safe? I had a patient who came to me yesterday and said, when this vaccination is available, assuming you're part of tier 1, which I am, will you be vaccinated? And the answer is resoundingly yes. And I'd like to explain a little bit about the vaccination and how it works. The vaccination is actually one of the very first times we've ever used mRNA as a vaccine technique. The standard vaccination technique is that you take a small component of a virus, in this case, and you expose a person to that virus so that they build antibodies and T cells that when that virus invades their body again, but this time for real, they recognize that. It's the equivalent of taking a picture of somebody, and when you do, you only have to take a picture of their face. But if you ever see that whole person in the future, you'll recognize that person based only on the photograph of one very small part of their body. And that's essentially what we do when we vaccinate people. We take a small subcomponent of the virus and we introduce that to a person's body so that they produce specific immune components that will recognize that virus the next time it invades a person's body. So it gives you a lead time and a jump start on producing an immune response so that you don't need to start combating this in a fresh sense. You actually have an educated immune system. mRNA is a little bit different because in the past, what we've done is given proteins that are associated with the virus. And in this case, the spike virus, which is where the coronavirus gets its name. And but in the mRNA vaccination, what we're doing is not giving the virus, not giving any specific part of the virus. We're instead giving the body instructions on how to produce a small part of the spike protein. And your body does that with the mRNA, which is essentially instructions on how to build part of the spike protein. And then that spike protein is subsequently destroyed, and immune complexes, which are antibodies, are produced, as well as T cells. And that specifically will combat that in the future. Can you get the virus from getting this vaccination? No, and the reason is because the virus includes an envelope, it includes spike proteins, and also it contains genetic material. Those are the 3 components. You would theoretically have to have that entire viral particle in order to get infected. And the mRNA vaccination is not doing that. It's only giving instructions to your body on how to produce a small part of a single protein. And so it would be equivalent to asking the question, can a photograph of the bad guy hurt me? And the answer is no. It'll only cause you to be able to identify him in the future. And but there is absolutely no way that a person would be injured by a photograph, and essentially that's what the mRNA is. Do they work? Yes, in fact, we've got great evidence that they're doing a great job, and it appears that upwards of 95% of people do receive immunity. How long is that for? We don't know, and a lot of that's going to depend on specific issues. But I think in the beginning, at least people will be vaccinated for a certain period of time. It'll buy us some time to respond and to perhaps come up with more definitive ways to handle this. So it's a very exciting technology. I think this is by far the best news that we've heard so far. Is there any other issue such as can this cause cancer? And the answer is no, because in general, this could never enter the nucleus of your cell. It doesn't really have the capacity to do anything dangerous as far as we know, and that's absolutely been well studied. It's one of the reasons that the US government is taking a bit longer to approve vaccinations than other governments have. Certainly the Russians approved something very, very quickly. We don't know much about that. Doesn't really appear much in the news these days, which my supposition is that it's probably because it's not working fantastically. But I think that the English, of course, have approved this probably days before we have. I don't think it's a significant amount of time. I think they're also a very cautious culture, but they have access to information that's caused them to feel more comfortable than we've felt so far. So happy to answer other questions specifically about this. Members of the community, any other people who'd like to ask questions about the vaccination safety and various other issues. I'd like to return back to what we talked about earlier. I'm hoping to open up a discussion with other board members about recommendations for the specifics on how we can best address our community, our constituency, and specific methods by which to deliver the message that we'd like to deliver. And thank you very much, everybody.
Thank you, Dr. Stringham. I think the first thing we probably should do today is to follow up with Dr. Stringham on board members' thoughts on how we may be able to get some sort of a meeting out, how we need to proceed. I'll just go down the list and see if you have any thoughts and any suggestions. We'll start with Commissioner French.
Thanks, Mr. Chairman. I'm kind of at a loss at part of this. I wrote a number of notes down with Dr. Stringham's presentation. I do agree that we have reached a point where we are. I think we have a much deeper problem community-wide than just doing the right things. And this is my opinion, and this is based on conversations I've had with public up to this point. But we're running into something right now, and it comes back, and I thought about it as we were discussing the CDC recommendations having to do with reduction of the quarantine time. There are people that have actually communicated with me that are very reluctant, who have symptoms, who feel like they have symptoms that are consistent with it, and who are reticent to go in for testing because they simply cannot afford to be quarantined. And they feel that when you tie that with the notion that that is not a deadly virus, it is nothing more than what we're dealing with, seasonal flu. When you tie those two perceptions together, it creates this group of people who could become super spreaders within our community, who, for one reason or another, feel like they may have been infected, are actually going through the motions of actually convalescing on their own, and actually avoiding not only the testing protocols, but whether or not they're going to answer the phone from a contact tracer as well. That is a completely different that's a completely different issue, and I think it concerns me a lot, because I think a lot of us want to do the right thing. A lot of us have been I think the vast majority of our community is trying to do their part with regard to the spread. But I still believe that we have we need a message to go out almost through the employer side of it that would address that issue. That is one of the first things that I felt that we needed to bring to the forefront. Is that the second one is that why are we, and this is, I'm just paraphrasing a comment that I heard, why are we spending so much effort and energy and time trying to slow the spread when we know that a vaccine is imminent and is very close to being administered? And I think Dr. Stringham touched on that in his presentation, but I believe that we have a misconception within the community that there really isn't a need for us to be moving forward with this at this stage. And I think ultimately the message needs to be crafted around what does it look like after vaccination if we continue down the road we're on right now. I think the perception on the part of people is that it is going to take care of itself. And I think from what I'm hearing from Dr. Stringham and other sources as well, is that that's not necessarily the case. I wish I could offer a little bit more than that. I'm thinking about it right now, and I'm actually making notes, and maybe I'll weigh back in on this at a few more minutes after I've had a chance to collect my thoughts. Thank you. Thank you, Commissioner.
Thank you. Sheriff Fallon, do you have any comments or ideas?
Yes, good morning. First of all, a quick question well, I'll follow that up last, I guess. You know, on how to get out to the public is what my thought would be, is that we send flyers out to every door, every PO box in the county, and maybe include on there, if I caught Dr. Stringham right, that Zoom type or team type meetings, and we have specified dates and times where the public can tune in to get the information they need for the vaccine or the latest information on the virus. And so now I do have two other questions for Dr. Stringham. One is, quickly, how are we seeing it spread again? Is this from family gatherings? Is this why we're seeing such an uptick, spike so quick? And then the other one, are there different strains of the coronavirus? And those are my questions for Dr. Stringham.
Yes. So essentially, the virus is really being spread in social environments, in non-formal gatherings and things of that nature. And there's a very common theme, a motif that I see. And the example I've used with patients is that if you're watching a football game, there are times that the ball is in play, and then there are other times that there's a timeout and the ball is out of play. And it's understood that that the out of play times, that it's not fair game to do anything. There's no movement in the game that's going to happen. But if coronavirus were a football game, essentially what would happen is while there was a timeout called by one team, the other team would just continue to play. And they would advance the ball, and there'd be a discrepancy. And in this case, the referees would say it's fair play. You're allowed. There are no timeouts, and the movement that you made of this ball is fair game. It's staying where it is now, and people are often outraged. I've seen cases where people get together specifically to talk about coronavirus. They're officials. That's what their job is. And boom, one of them winds up getting infected as they're sitting there talking about the virus. For some reason, most of us see where we can take a time out if we want to. And in the virus, you can't. And so if a person is a proprietor, for example, it's very likely that there will not have been a single case at that person's store ever. Not even never that there will have been people who've come to the store with the virus, but it's very unlikely that there will have been any successful transmissions at that store. But then when those employees go home in the evening and invite each other for a few drinks, for whatever reason, I can't tell you why, they they just see that as being a timeout. It's a time to decompress, to relax, and the day's been successful. Everybody's been fine. And what they don't realize is that they're sitting there talking about the virus and other things that they talk about. They're actually transmitting it right there at their dinner table as they invite guests in. They wouldn't think about doing this at their store. They wouldn't think about doing this at the school. They wouldn't think about doing this at the hospital. They wouldn't think about doing this at any other business. But for whatever reason, when people go home with peripheral family members, nuclear family members are different, but because we're all in the same family and we kind of share things to begin with. So this is peripheral family members and friends. And for whatever reason, we let our guards down, thinking that we've called a time, and there is no such thing. So that's the common theme of how this is transmitted. We're seeing quite a lot of that. You had a second part of the question, and I've forgotten what that was.
Yes, is what I asked. Are there different, we were on a conference call and somebody brought up strains. Will the vaccine handle all the strains of coronavirus? And I haven't heard anything that there are different strains. And I'm just wondering what you know, if there are different strains. And do you feel that the vaccine will handle anything coronavirus related? Is what I was wondering.
Yes, in fact, there is a primary strain, and then the primary secondary strain, the most prevalent of the secondary strains, is called D614G. It has a mutation in the spike protein, and that spike protein is a little bit different. It is more infectious than the standard virus, and at this point, it is probably more prevalent. Started in Europe, and it's now the most common virus variant in the United States. But I can tell you that it started between 6 and 9 times more infectious than the initial iteration of the virus. But the good news is that it is even more susceptible to the vaccination. So it's a little bit of a change in the configuration of the spike, and makes it enter cells a little bit more efficiently, but for whatever reason, it also makes it more susceptible to the vaccination. And so the vaccination antibodies that are produced are still effective and still work against that. I'd heard also that there was another variant that we were seeing here in northern Nevada, and I suspect that may have been an article that was written specifically about D614G. I've attempted to corroborate the story, but have not been able to talk to anybody who was cited yet in the article that came out in one of the news stations in Reno was the source of that. But so as far as we know, the two primary mutations, two primary iterations of the virus are both corrected with this antibody.
All right. Thank you, Dr. Stringham. Thank you.
Thank you.
Doctor. Commissioner Bell.
Yes, Commissioner Bell here. Share the same concerns that Commissioner French had brought up earlier. I've had a number of folks that I've talked to that are showing symptoms or anything like that. They just don't want to come in and even tested. Being as the testing protocols, it just takes such a long time to get a result. So tremendous amount of misinformation out there, and I think the folks are just kind of, frankly, just tired of this entire affair. And so rather than coming in and getting tested, they some of them will self-isolate. Some will still actually go around and keep spreading the virus, and I think that's why it's so much worse this time around than it has been in the past. And to combat that, I don't know, if there's, maybe if they're quicker turnaround times than what we've been having, where they feel that they could get tested and have an immediate result, such as in the rapid test that we don't typically do. They're kind of reserved for other folks. So I don't know if there's a process that we can do to get quicker testing. I think that would help make people, I'll just go get tested real quick. If I know within the next day or two, that's not a big deal. But if it's going to be 7 to 10 days, which is your quarantine period anyway, why bother? So it's just kind of some of my thoughts, and I'm not sure if there's any answers in how to fix all of that. So that's all I had. Thanks.
Thank you, Commissioner Bell. Commissioner Cherry.
Yes, I'll echo the same things that Commissioner Bell and Commissioner French said. I hear the same things. There are people out there who are know that they possibly have come down with it, who just are refusing to get tested. Not that they don't think it's serious, but unless they get really sick, I think they feel that they can deal with it without the test. I think most of those people are still, even if they're not being tested, are trying to do the right thing, self-isolating, that stuff. But I don't know what the answer is either. I think, you know, we've said it a million times that people are tired of it, and what they're seeing is the infection rate growing, and I don't know if it's a feeling of inevitably they're going to get it anyway. So, and I just a comment too that I want to make is I'm glad to hear Dr. Stringham said that we still believe that taking a moderate approach is the way to go. Because like Dr. Stringham has said a number of times, that we won't be able to test our way out of this pandemic or virus. I also think that we can't mandate ourselves out of this pandemic or virus, that it actually has the opposite effect. The stricter that we make it, the, you know, we're divided. There's a divided feeling out there too. Some are very concerned about it and have all the right to be, could have underlying conditions. And then you've got those that are fairly healthy who feel it's no more than just the flu. How we can get the message out, I really think that we have gotten the message out. I think everybody knows what's going on. I would be surprised if the large majority doesn't check every day to see how many new cases there are. Everybody I talk to seems to know what's going on. There's just a difference in opinion on how grave they're taking this. I have one question too for Dr. Stringham. I heard on the news this morning that this vaccine will require 2 shots. I think they said 28 days. In 28 days, you have to get a second shot. So, will you have any level of protection after you take the first shot, or will it take the 2?
You know, initially it was designed to be a one-shot vaccination, and then what they started to realize was that giving 2 shots had much better efficacy. And so what would happen is there'd be a certain period of time that would be required for a person to produce those T cells and also antibodies. And my best guess is that likely happens within a couple of weeks. There's probably a certain degree of immunity after about 10 to 14 days. And I'm just kind of speculating about this, that it likely pinnacles sometime around 45 days or so. And then that second vaccination is not absolutely required. It's just a really good idea and absolutely adds to the efficacy of the vaccination. There were even some questions about whether or not a person could start with Pfizer and end with Moderna, and that really hasn't been answered. But definitely when people have 2 vaccinations, the series of 2, their immunity is much, much better. And I would say that to answer your question more specifically, you're going to see some degree of immunity within about 10 to 14 days, and that will increase as time goes by.
Okay, thank you.
Okay, thank you, Commissioner Cherry. I know myself, listening to what the other commissioners and sheriff have said, and Dr. Stringham, I think our testing is a big problem, and it's been brought up here a couple of times already today. We have to have a method to do testing at a because there are many people out here that they can't afford to quarantine for 14 days unless it is absolutely sure that they have it. I mean, they're trying to pay their bills and they're falling behind, and they may be afraid of losing their job if they have to take that much time off. And I think there's a problem there. I've had some comments on the contact tracing that's taking a long time, and I know we're probably behind with the surge in positive cases that we've had. But there again, if you have known infected people and the contact tracing isn't at an adequate pace, then you have people that are probably positive still going around spreading the virus if they haven't been contacted. I see another problem with CDC, and they're dealing with something that they've never dealt with before too, but they've changed their position so many times that a lot of people, they just kind of laugh about it and say, well, the CDC they'll change their mind again next week on what the right thing to do is. So, you have those things going on, and like Commissioner Cherry said, you have the divided opinions. But maybe we could get a Zoom type meeting if you had it a couple of different times, so people could hit those Zoom meetings if they wanted to. You might get through to enough of the population that is an opinion that they don't think it's really bad, but they're not sure. That you might get through to that group. I don't think you'll ever get through to the group that just doesn't believe it. It's a real bad thing, that it's just going to pass through and we'll be over it. But we might get through to some of those other people and maybe be able to answer some questions. Dr. Stringham may be able to answer some questions that there's a lot of rumors going around and different opinions on that really doesn't have any science to back them up, and he would have that science to actually clarify the I don't know. Commissioner French, do you have any other ideas there?
Thanks, Mr. Chairman. You guys are spot on in terms of what I think is the issue within our community. I believe that even both sides of the as was pointed out, there's kind of divided group of folks as to whether they believe in this as an issue or not. But I think both of them would agree that that if for no other reason than to protect their businesses, their hospital, and people who may be utilizing that hospital for things other than COVID-19, for no other reason than that, to take a run at being responsible in terms of the spread of this virus. Because whether you believe whether you believe that the virus is a problem and is lethal to portions of our population, whether you believe that or not, one thing we have to agree on is that we're filling our hospital full of people who are sick with COVID-19. And that's all across the country right now. That you can't deny that. I mean, and that is what separates this from the other viral infections out there on the ground. We also have the potential of completely closing businesses down following an infection within its employee and within their employees. We've already seen that happen in this community. So I think that from that standpoint alone, I think we should take a run at that group of people who don't think it's a real problem. Having said all that, I had one question for Dr. Stringham that I had written down that that somebody had asked me about last week, and I wanted to ask him before we move on, having to do with convalescent plasma protocols. I know CDC has a call out asking for those people who have been infected within the last 4 months, to consider donating blood for convalescent plasma for those people who are very sick with the and I'm wondering what the protocol is for collecting convalescent plasma within our community.
You know, I can certainly answer that question a little bit better when we visit next time. I don't know exactly what our system looks like. I know in a general sense that the convalescent plasma comes from many, many different places across the United States, and it's made available through the system. And so it's a wonderful technique. It's very effective, and especially in those patients who are very, very sick, giving convalescent plasma is extraordinarily effective. So it allows people to have access to the antibodies that they need in order to be able to fight this. Interestingly, the vaccinations also have some of those same effects, even for the people who become ill who've already had the vaccination. The probability of the infection getting severe, having massive consequences, ending up in an ICU is very, very, very low. And so I can ask specifically whether we're collecting convalescent plasma here in Humboldt County, either for use here or to potentially be used through another agency. It's a great question. I wanted to answer a couple of other questions that have come up that I haven't had a chance to answer yet. First thing is testing speed, and it's a great question. I can tell you that a number of us have worked very hard on that. We have a 2-day turnaround in most cases, 3 at most. So it's way, way down from the days when we had 10, 12, and 14-day turnaround times. That is absolutely a thing of the past. Humboldt General Hospital did develop a relationship with Quest Diagnostics, and the tests are all being sent off there. We do not specifically have to request it. HGH does that anyway, and they've really helped out in speeding things up a tremendous amount. The other thing is that we have the Binax now testing capacity that is a rapid type of a test, but it works differently from the way that the conventional Abbott rapid test ID test works. And it's not as short supplied. And Captain Wilkin has been successful in procuring 5,000 additional tests. Public Health Nurse has quite a few of them now. HGH has some too. And HGH will be very quickly in the next couple of days having a protocol to actually do that. It's taken a while to get the authorization, but I know they've been working on that very diligently. And so testing speed it has really been handled. I'm very happy with the way things are going at this point. The other thing I would say is in terms of people who become infected and what are we going to do with those people? How do we contain those people? I would say this reminds me a little bit of supply and demand side economics. I think I would worry less about containing those people who are infected, who aren't admitting they're infected and wandering around in the community infecting other people, and handle it from the opposite standpoint. And that is if every single solitary person does not let their guard down and constantly stays vigilant, doesn't let anybody from outside their nuclear family get within 6 feet of them, and always wears a mask, then everybody can be infected in the community, and the one person who's not will not get infected. So this is about taking responsibility for the people who are willing to engage, because if the engagers take responsibility, then the people who haven't engaged are no longer a threat. So this takes 2 sides, supply and a demand side both. Have to have an infector and an infectee. And if the potential infectee never lets his or her guard down, then the infector can wander around without any danger whatsoever. So we have to deliver the message to the people who are willing to hear it. And I think our primary target now is not so much people who are not willing to engage, it's people who are willing to engage but are fatigued and are spending their energy doing the wrong things. They're checking their temperatures, despite the fact that only 12% of people with this virus have a fever. And but then they're foregoing other things that are that really would be a source of safety. So they're concentrating their attention in the wrong areas and becoming fatigued by doing the wrong things, which doesn't allow the energy to actually do the right things. And the other thing I think is that we can to bolster engagement by having these question and answer phases. We get buy-in when people can ask their questions, when people can challenge me and say, why do I have to pay attention, or why is this that dangerous? And I'm happy to answer those questions for individuals on a massive Zoom meeting so that people can actually challenge us. And when their questions are answered, hopefully they'll engage.
Thank you, Dr. Stringham. Would like to go right now to a couple other individuals here. Commissioner-elect Hill, are you on? How about Commissioner-elect Haas?
I'm on here. Ken, can you hear me now?
Yeah, we can. Jesse, go ahead.
Sorry. Yeah. Did you have a question for me?
Well, I wanted to know if you had any comments or questions of Dr. Stringham, since you and Commissioner-elect Haas will be on this board starting next month. So wanted to hear from you.
My thought is this community-wide Zoom meeting would be great. I think it would be great for people to hear from Dr. Stringham himself. You know, he's a pretty convincing guy. You know, versus just a radio ad. You know, actually hear from the doctor. You know, I think that goes a long ways with convincing people to do the right things. I think it'd be great.
Okay. Commissioner-elect Haas?
I'm here.
Do you have any questions, comments, ideas?
Yes, I was just waiting to be unmuted. I believe the Zoom meetings would be a good way to start this out and see what kind of response we have with it. You know, we do fairly well with the Zoom meetings and whatnot. And those that want to hear or want to see will, and you know, we can get started there. I do hear a lot of different stories throughout the community of how this is getting handled within the community. I, you know, got to take my hat off to the businesses, because there's not been very many COVIDs coming out of the businesses, and they've been open all this time. That's all I've got to say.
Thank you. This time I'm going to go off path here a little bit, and we'll ask for anybody in the public that would like to ask a question or make a comment or have any ideas on how we can reach out more to the public. And just unmute yourself, *6, and please identify yourself. Do you have anybody who would like to talk?
Ken, this is Michelle Hammond. I have a question for Dr. Stringham.
Okay, Michelle, go ahead.
Dr. Stringham, I had a question in regards to this first round of vaccines that are going out. And I know that vulnerable populations in particular are patients at Harmony Manor might be in that first line of getting vaccinated. And my grandmother is there at Harmony Manor. And some of my concerns have been that I haven't seen any research coming out on the effect of the vaccine on our elderly population or our more vulnerable population. Have you seen any of that, or do you have any insight?
Yes, absolutely. I read just last night, there was an article that was written in aging populations about immune responses, and the responses are actually quite good. I've been very impressed by that. It's interesting that in other cultures, in the United Kingdom, for example, they're going to be handling things a little bit differently in their tiers than we're going to be handling things. And they're actually going from oldest ages first down to younger ages subsequently. And in the United States, we're not doing things like that. So, but one of the reasons they're doing that is because it absolutely has been shown to be effective in aging populations and middle-aged populations. It's effective across the board, really. So the results are really good. So yes, it will have wonderful effects in older people.
Okay, anybody else?
Oh, okay. Just in addition to that, because we haven't been able to go in for visitation to see our relatives since March, there was a small 3-day window that we had an opportunity. Once those vaccinations take place, are we going to see some of those restrictions being taken off, or will it, be determined still on us as a general population being vaccinated prior?
My suspicion is that that'll come a little bit later during the vaccination process. There absolutely will come a time when it becomes safe again to visit elderly relatives in nursing homes. And I can tell you that most of the decision makers, including those here at our hospital, Humboldt General, are very sensitive to the needs of families. All of us have families too. My own mom passed away in a hospital back in July, and my ability to visit her was not what it should have been. So this is it's something very near and dear to all of us. And and I can absolutely assure you that later during the vaccination process, as more and more people gain an immunity and there are fewer cases of the virus, it will absolutely become possible again to visit folks in nursing homes.
Okay, thank you. Dawn, I see you have your Dawn?
Yes, Dr. Stringham, this is Dawn Hagnes from Humboldt County. Just a couple of questions regarding the vaccination that we've talked about. Will people who have already tested positive previously be required or need to take the vaccination?
You know, I don't know what the answer is to that question. I know that I've heard a couple of different things. First, even CDC at this point is saying that people should consider themselves immune to the virus for about 3 months after having had the virus, and that at that point the immunity is less impressive, and not all the way across the board, but that's kind of the general rule. And we require that people quarantine if they've had the virus in the past, if that virus infection period was greater than 3 months ago. And so really the question will come down to whether that person still has immunity, and we can test by immunoglobulin type G, IgG concentrations, things of that nature. My guess is that there will be a protocol that's developed as the vaccination becomes more widely available. And because theoretically a person will lose immunity at some point, and that has to be addressed.
Okay, so in that same token, then, would it be expected potentially that people that receive the immunization, if they are part of a direct contact to a positive, would they still need to quarantine?
You know, if the person has immunity, and if we know that the person has immunity, then no, they would not have to quarantine.
And we would assume that that sounds like better off if they've taken that second dose of the immunization. Or 10 to 14 days after that first dose, would we say that they then wouldn't even have to quarantine?
My recommendation is that I would still quarantine a person here in Humboldt County if the person has not yet had that second dose. And so they will absolutely start to develop some antibodies and T cells as soon as 10 to 14 days, but I wouldn't rely on them being incapable of acquiring the virus until the second of the vaccination series was done.
Okay, thank you. That's great.
Yeah.
I had one other question, Dr. Stringham, that I just saw in the news this morning about finding in blood drive draws that this virus was probably already clear across this country in early November of last year. I didn't read it completely this morning, but there was a news clip on that.
I started to see that story come out, I believe on Monday, and so I'm familiar with that. I've read about that. I think that when there's a lot of conflicting information, you have to keep your wits about you, and it's important for all of us in the sciences to just keep asking ourselves the one pivotal question: does this seem reasonable to me? And what I can tell you is I'm sure that the virus was here to a small degree in the United States. And I'm certain that it started before we thought it did. But I think a couple of different things. First, there's been kind of a decentralization in an attempt for China to kind of exonerate themselves. And so there's been some information that I've read that seems dubious as far as that goes. And so I look at kind of motives to say certain things and to write certain things. And that's one of the issues. And then the other issue is that if you look at a boat moving across a lake from an aircraft, you can absolutely see where that boat's been. And there's just no question. And especially once the boat picks up speed, you're going to see a wake, and you can just, there's almost a record of where it's been. And what I can tell you is that I have a hard time believing it was here that early, because it is so infectious, and we just didn't see a lot of cases. On the one hand, we didn't have the ability to test it until sometime in mid-March. But at the same time, we weren't seeing the things that we would have expected to see like people having unexplainable illnesses. And in a lot of cases, now that we've had the antibody tests available for quite some time, I've actually gone back and tested people who've sworn that they had the virus back in January and February. And in about 50 tests that we've done so far, I've yet to see a single person who really had it. So the first case in Humboldt County was 25th of March. And I've yet to see a single case to the contrary. And as with most of us, I include the things that I see myself as being the most proximate source of information. So I can't tell you that it wasn't here that early, but I can tell you that certain people have a motive to say that it was, and I've never seen any evidence that it actually was.
Okay, thank you. Do we have anybody else from the public who would like to talk? Road train in behind him.
This is Patricia Tyndall from the Senior Center. I'd like to ask Dr. Stringham, if you get the vaccine, are you still able to get the virus? Like when you get a flu vaccine, you can still get the flu. It's just a really lighter dose because your body can fight it off. And if the answer is yes, you can have the vaccine, but you might still get the virus, you can just, if you get the vaccine, are you still able to be a carrier?
That's a wonderful question, Patricia. I think the first is that you remember H1N1. There are two different sub chains on the influenza virus, the H and the N. And between the two of them, there are about 150 different possible varieties of influenza. About 120 of them occur naturally. And every year, we guess the ones that'll be prevalent that year and give between 3 and 4 different variants of those viruses. And if you guess wrong, then the person still can get the flu. And so it's a very different type of a strategy with coronavirus, COVID-19, SARS-CoV-2. You only have 2 different major variants that we know of so far, and both of them are, you gain immunity to them with this vaccination. And so I would say the answer to your question is, if you get the virus, if you get the vaccination, there's probably only about a 2 or 3 or 4% chance that you could get this virus in the future, as long as you have an adequate immune system and you actually mount the immune response that you should to the vaccination. So in that sense, it will be substantially more effective in preventing a person from becoming ill than the influenza vaccinations. With that being said, still critical to get your influenza vaccinations, because the most likely way to pass away with this virus, with COVID-19, is to both have influenza and also have COVID at the same time. We have a community member who passed away just that exact way recently. And so very, very critical to get the flu shot.
And if you do get the vaccine, can you still carry the virus? Can you still pass it along to somebody else, even though you wouldn't get sick? Or are you not a carrier anymore and it's all done?
In terms of being a carrier, I don't know that there really is a carrier state the way that there would be with various types of bacteria, things of that nature, streptococcus, things of that nature. There certainly are asymptomatic people who have infections but don't have symptoms. And but what it means to be a 94.1% effective, which is what Pfizer is reporting, it means that approximately 5% of people will not respond to this and won't develop adequate antibodies and will not gain immunity. So for a person to theoretically be quote unquote a carrier, infect other people even though they've been vaccinated previously, that person would, number one, have to have had the vaccination but not responded to it. That makes them a member of a 5% group. And number two, they would have to have the virus and be infected but yet have no symptoms, which is also not super common. And so it would be a very unusual case where a person could infect another person even though they had been vaccinated previously and didn't have symptoms.
Follow up to that question, Dr. Stringham. If I was to get this virus hypothetically today and I didn't feel any signs of it, and tomorrow I received my first vaccination, would that vaccination take time to really start to work? Would I more than likely still get the COVID-2, or would I start to draw some immunity from the vaccination immediately?
It's a great question. So the question really speaks to how fast our immune response will happen with vaccination. And the answer is it is going to take some time to develop that immunity. So if you theoretically had both an infection with no symptoms and also a vaccination at about the same time, you would in all likelihood wind up developing the virus. And the immunity that you would get, essentially it would be the equivalent of seeing a picture of the bad guy as the bad guy enters your house. And you get some forward information as to what's about to happen, but your immune system would not have a chance to respond. And so essentially you'd still have to deal with the bad guy, even though you got a picture of him just a few seconds before he came into your house.
Okay, thank you. Any other questions from the community? I still see a hand up from Don Hagnes. Did you have another question, Don? No, take it down. Okay, at this point, what do we want to do? Does anybody have an idea that we should put forward as far as how to set up a Zoom meeting? It seems like pretty much everyone is in favor of that.
Commissioner Tipton, this is Commissioner French. I might, if I could add something to this, I'm thinking about when we had just drawing on some of our experiences with community involvement in the past. We had issues with nitrate contamination in groundwater in Grass Valley, for instance, and we moved forward publicly in order to try to inform people that where this was and what the risks were to them, and how we were going to remediate the problem in the future. I think from that standpoint, if we had a community-wide COVID-19 meeting, Zoom meeting, having to do with questions and answers, as well as what's the state of COVID-19 in Humboldt County at this point, and what are our challenges? And then really, as we did with the water plan and the source water protection plan, really go forward with a blitz with regard to informing the public that this meeting is going to happen. Because I remember when we put that first community meeting together having to do with the source water protection plan, and we actually advertised it vigorously beforehand, we had I thought was a very impressive turnout in terms of people who are interested. And not only did they turn out, but they actually took that message home with them. So I think ultimately, we should start with that. I think we should start with a blitz in terms of the meeting, the intent of the meeting, having a general community-wide Zoom meeting having to do with the state of COVID-19 with regard to our population here, what our challenges are, what the good news, what the bad news is going to be, and then take that Q&A for either members of this board, but probably in particular Dr. Stringham, I think would be very beneficial. And I think that's the way that's what I would propose that we do, is that actually start this process with a community-wide meeting.
So Commissioner French, if you do this community-wide meeting, would you put into that Sheriff Allen's comment about sending some sort of a card out to every address in the county advertising the meeting and how they would get on the Zoom meeting, the instructions? There would be a lot of people probably would like to get on a Zoom meeting that may have not ever been on one?
That's a great question. I think that would be just one of the places, one of the ways that we should be able to do this would be to put a flyer out and get it to every post office box and every address out there, but also possibly providing access to Zoom technology through some of our infrastructure that we might have within the county. I'm thinking about the library. I'm thinking about, I remember we had the same conversation with the source water protection plan and how can people get on this short of coming into the meeting? How can people actually access this kind of a meeting through remotely? And they were talking specifically about some of the northern communities that were more rural in nature. I think ultimately that's one of the things I think we could possibly think about from a county perspective as to how do we get to those folks that could not access Zoom, and how can we possibly involve the vast majority of the public in terms of advertising for this meeting, whether it be through and including a flyer, whether it be a public service announcements, whether it be involving word of mouth. It went very, very quickly when we started talking about this source water protection plan. I think we were 3 weeks out when we started really advertising for that, but I think the result was impressive. You know, putting a notification on our signs and whatnot in our electronic signs at our convention center and at the front end of town, getting it to all of our service organizations, the leadership in those service organizations, getting it through our Humboldt County School District so that they can take it home to their parents, that conversation. But really have a summit. We called it a water summit, if you remember. And let's have a COVID summit in our community. Let's have that meeting to where we can talk about and lay out the state of this county with regard to COVID-19 and what does it look like if we don't move forward with the recommendations from this board before vaccination and even following vaccination. What does it look like? So I think that's the only way that's the only thing we haven't tried so far, I guess is what I would say.
Okay, thank you. Any other comments or questions before I ask for some sort of a motion?
This is Patricia again from the Senior Center. Is there any way to do a summit and have somebody be a translator and put some of this information into Spanish?
I could help you with that. This is Giselle, the crisis counselor for Pershing County. I've been translating over here for Wendy Nelson, for my supervisor, Farkas, and for Dr. Van Gelder. If you want, I could give you my information. I'm bilingual, speaking and writing.
Thank you, Giselda.
This is Abel, Assistant County Manager, HR Director for Humboldt County. Would it be wise to have maybe a separate session in Spanish, maybe on the same day? Or maybe if we have it at the same time, have two different logins, but it would be nice if we had a separate session, one in Spanish, then we can invite the doctor and translate in Spanish. So maybe just a thought, something to think about.
Not a bad idea, Abel.
It's a great idea,
good.
Abel.
This is Leah Farkas. I'm Giselda's supervisor with the Nevada Resilience Project, and we would be more than happy to help facilitate that presentation and in Spanish. If you're interested, I can get you, or Giselle can get you my contact information, and we can help you set that up.
Okay, thank you. If you would, if you could reach out or send that to the county manager's office or to the assistant county manager, Abel, he could help you with that too.
Absolutely.
Commissioner French, would you like to make a motion?
Yes, Commissioner Tipton, I wouldn't mind that at all. I think,
Mr. Chair, I'm sorry. You cannot make a motion on this. We're in an item that is just informational only right now. We don't have any item that I think Wendy can weigh in here to do that. I would suggest that we've taken this as information. When we get to Nicole here in a few minutes, she's going to talk about a flyer that we've already worked on. We're about ready to send it out. And as far as doing the other stuff, I'm perfectly easy to do that. I don't think we need a motion or an action item. We can certainly just follow up with it and or bring it back to another meeting if Wendy thinks we actually have an action and to take a vote on it.
Okay, I'm sorry about that.
So this Commissioner French again, I need a clarification on that. So Dave, ultimately, it's the thought that, you know, we're just making a decision based on or a recommendation based on information that we've received. And it's not going to require a public motion or a consensus on the part of this board. It's just to move forward with that recommendation.
Yeah, and what I do is normally take recommendations and hear things, and then Nicole and I will huddle up to discuss how do we actually implement those things. But again, with respect to open meeting law, there's nothing on our agenda that I can see that would give us the ability to take a vote on something like that. So because what we're under right now is item 4, which is just informational from our 3 expert on those areas. So I would just say I got the message. We'll work on some things, and like I said, I like the idea of the Zoom call, if you will. We need to find out what our maximum capability is here at the county to do it through our current platform, which is Teams. I don't know if there's a maximum number we can handle, but I'll check with Tim on that and I can get back to the board. So yeah, we'll follow up with that, but I see, well, first, I don't think you can make a motion, and number 2, there's no need to.
Okay, thank you. At this time, is there any other questions for Dr. Stringham?
This is Commissioner Cherry. Just some thoughts I want to throw out there is that the timing of this Zoom meeting would be critical. Otherwise, we're just going to get the same people that we have on our board meetings. Everybody works, so that would, you know, we'll have to think about the timing. It probably would need to be in the evening. Otherwise, it's going to be highly ineffective. I also think that we need to consider having Dr. Stringham would probably be able to answer 90% of the questions, but maybe some of those that we have on these board calls, someone from the hospital, someone from the school, city, those types as well, in case some questions came up that Dr. Stringham wouldn't have the answers to.
Mm-hmm. I think that's a wonderful idea, Commissioner Cherry. It would help to clear up a lot of misinformation that have come out, that has been put out in the community on our social media platforms, and maybe is not correct, and it would help the school district, hospital, and health board to get that information out correctly. We're going to move on. Now, I've got someone that wants to talk from the hospital. We're going to do hers, Leanne Cushway, because she has to move on. So we'll go to her, and then we'll come back to Captain Wilkin and Nicole. So we'll go to item number 6. And Leanne, are you on?
I am. Thank you. I appreciate it. So I'm Leanne Cushway. I'm the Chief Nursing Officer for the hospital. I just wanted to give a brief update on what's going on with us. Like Dr. Stringham mentioned, we've had a very busy influx. We've had 132 patients that were positive within a 4-day span. We're seeing over 100 people per day in the COVID screening clinic. 40% of those are symptomatic. We have over 200 pending tests right now. Our turnaround time has improved. It's 48 to 72 hours from Quest, like Dr. Stringham mentioned. But we are seeing a huge volume in our clinic area. So the drive-through, this should have gone out this week. It will be open 7 days a week. We're hoping that with 7 days a week, this is going to reduce our daily surge, where it is kind of stressing our staff and our system. And then we are increasing to 2 providers per day, Monday through Friday at the clinic, because one provider has been running 40 through on her own. We are looking at the BinaxNOW antigen test. We mentioned that the last meeting. This test is a rapid test. It still takes 20 minutes. It's done at bedside. And we have 250 of these tests currently in the hospital. We are still having challenges with the state approving it, even under the lab. The state, we've been calling daily. Now they're not even answering their phone, but we are ready to roll it out as soon as possible. The competencies are done, staff are trained. We're just waiting on that approval to use it. We have not received the 5,000 kits. Officer Wilkins is still working on that. We don't not have an ETA on that, but with the 250 that we have, we would go through those within a day or two. So we're just waiting on that. We do have in our lab antibody testing. So we did get the equipment in. We've started our QC trials on it. We've been able to run 3 studies. We are waiting for approval from the state to fully implement that. As Dr. Stringham mentioned, this will be a valuable test post vaccinations, and some more to come on that one. We are having an average of 5 positive patients per day inpatient in the hospital that are COVID related. We're running 72% capacity for our licensure. We did set up Rampart in the garage, and it is ready to go. So we can accommodate an additional 25 patients once we hit the 100% capacity within the hospital. We have been able to acquire additional staffing through travel agencies to manage Rampart for if we do need to open it. And basically our most critical staffing needs right now are lab related, because we are getting about 100 tests per day that have to be processed. So we are working with Officer Wilkin to get some lab support from the state. As far as critical patients, we've still been able to get them transferred out. We don't have anybody currently in the hospital that is on ventilated support. We've been able to get a few out to Renown and St. Mary's, but their availability is very limited, mostly getting cardiac related out to them. They have been unable to really take any more COVID positive that are critical. So many of those were going to St. Alfonso's in Idaho. And then Tim is met with St. Luke's Meridian in Idaho this morning, and he was able to get a transfer agreement there. So we'll have more capability of getting critical patients out. Everybody's mentioned the vaccinations. So we did receive our Sub-Zero freezer yesterday. So we will get that installed in our pharmacy area. Then we will be able to order directly to get vaccinations in and assist with the community efforts there. Like Dr. Stringham said, we have almost daily meetings on the vaccination and when that's going to be released to all of the facilities, and we're gearing up for that. Long-term care has stabilized. So currently the staff over there are doing an amazing job. We still have to test 2 times a week due to the county increase in positivity. But we were able to open up yesterday for some acceptance of admissions. We were able to admit 2 people yesterday because of our outbreak from staff-related illness over there has been removed from the state. As far as visitation, I know I heard those questions. The CMS will dictate to us when visitation can reopen. It will not be allowed for visitation unless the county COVID positivity rate drops. There's very specific guidelines the government has implemented on visitation, and they send us a report weekly and letting us know when we can open. And that's all I really have. I can answer any questions if anybody has any.
So, Leanne, seems to be the holdup from the state on the antibody test being approved?
So everybody received the BinaxNOW antigen test about the same time. And it has to go through the CLIA waiver that's under the hospital or the lab. And every hospital in the state of Nevada is trying to get it at the same time. So that's what they're informing us. They're moving as fast as they can. However, a lot of the state employees are now working at home due to the December 10th or November 10th mandate from the governor to try to stay at home. So many of these people are working from their homes, and it's hard to reach anybody and get anywhere with really pushing this through.
So I'm confused here. The BinaxNOW testing has not been approved yet. What about our antibody testing? Have we ever got that in place?
So the antibody test, so that's we've been able to start running our quality controls on that. And we've done 3 tests to validate that it's functional. We have to wait for the state to approve that piece of equipment as well.
In the
so
same,
that is on state, yeah.
so that's the same thing. Okay. All right, that answers a question of mine. Anybody else have a question for Leanne?
This is Commissioner Cherry.
Go ahead.
Leanne, you said that you're presently at 72% capacity. I think that was the number.
Correct.
Is that just is that an ICU or just a COVID unit, or where's that number come from?
Okay, so we're licensed for 25 beds by the state. So 3 of those beds are ICU, 7 are OB, and the remaining 15 are acute care. So that's 72% of all of those beds. The ICU, we've converted the ICU to a COVID area because of the negative pressure ability in that area. So we are running 5 patients per day. We do have ICU capability still. All of our beds are not filled in the ICU.
Okay.
So we're average daily is about 18 total for the hospital.
So if someone has a heart attack, there is still space for those types of issues, huh?
Correct.
Okay.
Most of the cardiac related events, even the MIs, the heart attacks before COVID, we transfer to a higher level of care for cardiology support. And so those are still able to get transferred out without any issue.
Okay, thank you.
You're welcome.
Anyone
Chairman
else?
Tipton?
Yes.
Hi, this is Director Sala from Juvenile Services. I just had a question about the testing time because I keep hearing that, there's a new contract and that testing times have decreased, yet I have some staff who were tested on last Friday and we still haven't received the results. So I'm just like, when did the contract just start, or has it been in place since last week? And us waiting for these test results is not, maybe it's just a fluke or something, but tomorrow will be 7 days and we still haven't heard.
So we recently did convert to Quest. Now, the holiday Thanksgiving, because Quest was not functioning on Thanksgiving, they have gotten behind. Unfortunately, when we sent 110 tests in and on one day, those are starting to trickle in. Janet is our infection control nurse, is the one that's monitoring all those. She is waiting for over 200 results today from what was the follow-up from Friday post Thanksgiving through yesterday. So they've been running pretty consistently, like Dr. Stringham even mentioned, 48 to 72 hours, but with the Thanksgiving holiday and the hospital surge, Quest serves all of our area, all of Northern Nevada. So it's going to depend on what influx they had as well.
I have a follow-up question to that then. So at least with our experience at Juvenile Services, because we have had positive cases with employees there, I guess my experience has been that positives seem to get notified much faster, which I understand why. But if it's a negative result, then my employees have had to continue to call to follow up on that. As we're a public safety agency and staffing has become difficult for us to cover our 24-hour facility, is there something that we can do that even if it's a negative result, we're notified, or at least my employees are notified much faster?
So one thing we did meet a couple days ago because it has been very difficult with staffing, even from the FAST command team, to keep up with all the phone calls. So we did shut down a line of service at the hospital because it was not being utilized currently during COVID. So we have 2 individuals now that are trying to call everybody, the negatives and the positives. So we've reallocated staff to do that. One thing I would recommend when people come in for testing, to make sure that their current email and phone number is given to the registration clerk, because if you have a current email in there, you can pull up your lab results on your own through the patient portal, through HGH website. We're finding that people are not doing that, and if they don't have a up-to-date email, they will not be able to pull it up. If there is a critical need, please, and you have an employee that is a critical worker, please reach out to Dr. Stringham. Dr. Stringham has great relationship with the hospital. He will notify myself or an ACNO of a need to do a rapid test with an employee that's critical, and we can run that through and have results within an hour back to that employee. So we have limited rapids available, but for public safety and for first responders, we've been able to keep up the demand for those get tested faster.
Any other questions?
Mr. Chair.
Yes.
Dave Mendiola, County Manager. Leanne, I have a question. Maybe you could do some clarification for us. You know, at one time I know that when we were doing the testing and it was going to the state lab, at least I believe it was free of cost. And that's kind of my question. Now that we've switched and we're going through Quest, how is that? What is the pricing on that? Because I have heard people saying they thought it was free and it's not, or in the case of, you know, the test itself might be free, but there's a professional fee as well. So could you kind of walk through that just so we get the information to people that's accurate?
Sure. And I know our marketing person just put something out on that on our Facebook because there was a lot of questions. So you're correct. The state lab is free, but we had to quit using it because the turnaround time was almost 2 weeks on some patients. Quest charges the hospital $100 for the test. So that's what the patient's getting charged for if it's through the drive-through. We're only charging them what it's costing us. There's no swabbing fee from the hospital on top of that. It's strictly just to cover the cost of the Quest test. If they're symptomatic and they need to see a provider because they want treatment or, you know, assure that they have what they need with them, there will be a fee to see the provider. And that's where the extra stuff comes from. We're also seeing influenza A and B. We're seeing strep and RSV. So when they see the provider, there may be additional swabs that are necessary. And so those are additional charges.
Great, thank you.
Now, when we get the Binac Now test going, those will be free.
Okay, thank you, Leanne. You said we're seeing an influx of flu A and B, and we're seeing strep, and what was the other one you said?
RSV.
Thank you.
And this is normal. It's seasonal. This is seasonal infections we see, and that's, you know, that's part of it with our influx of numbers. We're seeing a lot of flu. They're COVID negative, but they have identical symptoms, so they have to be ruled out for COVID.
Yeah, any other questions, Commissioner Bell?
No, I don't have any other questions. Thanks.
Thank you. Commissioner French?
I have none, no additional ones either.
Sheriff Allen?
No questions.
Okay, thank you. Appreciate
Thank you.
your report, Leanne. Okay, we'll go back now to Captain Wilkin.
Good morning. So the portion I'm going to talk about today is mainly going to be on the logistical aspects of the vaccine and the vaccine delivery and what the state's doing for planning. To start it off, I know a lot of people look for very specific answers in these things, and I understand that because it's leadership and government and the community wants answers and solutions to what's been going on. With the vaccine, I do want to clarify there's just some unknowns at this time because and we're working through those. We do seek to get the answers to those questions as fast as we can. For the health board and the COVID-19 teams group that is on there, I sent out the state's COVID-19 vaccination playbook. That's the most updated information. The state does treat that as a living document. So I sent the link rather than a PDF. That way, every time the state updates it, if you click into that link, that's the most up-to-date information we have. The goal of the Tier 1 vaccination program is to vaccinate approximately 80% of what's considered to be the Tier 1 workforce on those groups of 1 through 10 that I discussed in a previous meeting. Also, to go along with that, based on the CDC's recommendations, long-term care facilities got moved up into the Tier 1. So right now, 100% of the skilled nursing facilities in the state of Nevada are shown to be enrolled in the program. It's a partnership with pharmacies that are going to come in and do the vaccinations. This is a great thing for us for both emergency management and from the public health side, because that does take some of the workload off of us and allows that vaccine to get delivered. As of right now in Tier 1, I'm requesting 758 vaccinations into Humboldt County. 400 of those are going to Humboldt General Hospital. The remaining 358 will be delivered to our Tier 1 workforce here in the county. One of the hardest things about this is numbers of people that are willing to be vaccinated. And it is a very mixed reaction from, both the public as well as members of the Tier 1 workforce if they want to receive the vaccine. So I'm trying to work with the most accurate numbers that I can. I've worked with Dr. Jensen. I am going to do a bump down. So additional vaccine that I have, I'm going to allocate that to the school district in the Tier 1. The school district was in the upper tier of the Tier 2 category. So I think that this is going to be the most efficient use of that resource. Like I said previously, I just can't see wasting vaccinations that are brought in on these resource requests. Pfizer filed on November 20th. Moderna filed November 30th. The hearing for Pfizer is going to be on December 10th. And that's when a review committee is going to review the vaccine and decide on the emergency authorization. Everybody is anticipating that the emergency authorization is being made available. Nevada's week of distribution based on an emergency authorization is going to be the week of December 14th. We should see that shipped on the 16th, which is the Wednesday of that week. We will need to be prepared to deliver the vaccine that's coming in the 4 days that follow. We're looking at using a drive-through pod format to deliver the vaccine. And any of the remaining vaccines, I'm working with Dr. Jensen to be able to notify the school district on short notice that those folks can come in. And I have a tentative number from him of approximately 80 employees. So I think we're going to be in good shape not to waste. Going forward from here, Tier 2 is a very large group. Tier 2 covers retail workers, a whole different group of people from the community, and I have a list of it here. And I do want to go over it in this meeting because we're talking about with the other to have meetings for public outreach. That's going to be one of the things that I'm looking at doing, and I'm trying to come up with a survey that we can put out to the public, because Tier 2 encompasses a large portion of our public population here in Humboldt County. Tier 2 that'll affect us in our area is going to be education and childcare staff, Nevada System of Higher Education employees, our essential public transportation, agriculture and food processing, essential retail workers, logistics and supply chain, NDOT and local emergency road department, community support, airport operations, credit institution workplaces, so your banks and financial institutions, mortuary services, the remaining public health workforce who was not vaccinated in Tier 1, and additional critical infrastructure. And that's a big number in our county. With the vaccine, the state we're setting up 2 pods per. So we have the initial pod. They're giving me a 21-day time frame for the second dose on the Pfizer vaccination. So if we do a 2-day pod to vaccinate Tier 1, in 3 weeks, we have to be planning for another 2-day pod so that people receive the second dose of the vaccine. On the Tier 2, which is a very broad group, we're going to have to probably set up 3 to 4 days worth of pods, as well as do these 21 days after. I'm going to work with Marcia Foreman from Public Health. We'll need to bring that vaccine in a tiered amount, maybe 500 per week, something along those lines. So that way we can ensure that we can deliver the quantity of vaccine within a time that it's allowed to be thawed because of the 4-day turnaround. So there's a lot of logistics that go into this. And there's going to be, a lot of information that we got to try to get back from employers and the public. As of yesterday, we do not have an anticipated date for the Tier 2. Hopefully January is when we're going to see that made available, but I don't have a specific date. And then Tier 3, which is any remaining workers who don't fall into the Tier 1 or the Tier 2, that one is not going to be delivered through the emergency management and public health, from what was explained to me yesterday, speaking with Nevada Health. So that's going to be done through private or others, just like you see your doctor or pharmacy for your flu vaccine, things like that. So that's going to get opened up as a responsibility back to the general public. I think what Sheriff Allen brought up about doing the mailers is an excellent idea. Not everybody's on social media. We have a large portion of our community, elderly and other folks that they're not on Facebook. They're not logging in for Teams meetings or Zoom meetings and things like that. And I want to make sure that we reach that population. One of the largest groups of people that we've seen hospitalized during this pandemic are people over the age of 75 years old. So mail is often a good way to reach those folks. And I want to make sure that we're taking a whole community approach to getting the information out there, that we have this information that's there for them. Working through this, there's a reality going with this in the emergency management side, with the tier of vaccines at a minimum, with the release this month and a release in January, we're going to be at this through at least February to March with getting these vaccines delivered to our Tier 1 and Tier 2 populations. So it's something we definitely have to plan for. We're planning the logistics for it. But the Tier 1 vaccines coming out, it's not going to be a one and done situation. So we do need to make sure that we're logistically planning for a long-term investment in the delivery of these vaccines to our community and to our workers. Binax, I have an email into the state to the ESF8 desk on the Binax Now on the 5,000 tests to see if they know when they're coming out. I know that approximately what was explained in the meeting that we had earlier this week on Tuesday, 50% of the Binax Now tests have been delivered to the state warehouses. Those are initially allocated for school districts. So those are going out to the school districts that requested them first. And we should be receiving those Binax Now tests after the remaining allocations come in so we can get them out. But my understanding, it is still soon. And I know that was concern for Commissioner French in our last meeting. It is something that we are staying on top of and working on. They just have to get allocated because they were all government purchased so that they can be sent out through resource requests. So, and with that, does anybody have any questions on the vaccine delivery or things that I went over?
Questions for
Sean, this is Commissioner French.
Yes, sir.
I had you may have said this and I didn't catch it in my notes, but under the tier 2 group, did that include the high risk group for folks that are over 65 years old?
So let me pull it back up. And my understanding is it did not. I believe that those are going to be in tier 3. So tier 3 and number 1 in tier 3, which was our long-term care facility, they got bumped up into group 1A. That was on a CDC release, and the state's following suit with that, which I think is great. As well as NDOC inmates got bumped up into tier 2. So elderly Nevadans age 65 plus without underlying health conditions, which we estimate to have 207,603 of those folks in our state, fall into the tier 3 for people at increased risk. So they're in a tier 3 of vaccinations.
So that means under tier 3, that when are those people looking at the availability of vaccine for them after March?
The direct quote that I was given yesterday, Commissioner, there is no predictor on that time frame. So I don't know. I would have to say after March. I don't want to be incorrect about that. CDC and the state doesn't anticipate a shortage of vaccine once it's able to be released. So they anticipate being able to fill these orders and get this out to the public. So as of right now, and both in the playbook and what CDC says from the state and feds, is that we don't have a shortage of it. It's just getting through this process and getting this release done. So my hope is, and this is just my personal opinion and my kind of personal goals for this, is that we're going to see a really wide release of this vaccine once we get through this tier 1 during the first month, and that we see this getting out to our public. I know it's a goal of both the state and the feds.
Great, thank you. I know I'm getting an awful lot of questions on that, and I'm just wondering if the high risk group are those people, we've been hearing that from the beginning, are those people 65 and older? I think I'm surprised, I guess is what I'm saying, is that we're not targeting that group of people, because if our interest is not overloading the healthcare system with people who could conceivably need hospitalization if they do contract it, that would be the group I would be looking at first, or at least high on the priority list, certainly not on the bottom of the list.
Right. And that's, and these guidelines that both the feds and the, put out through the state, it's not something that we had input into as counties. And, really a very honest answer, this is a lot of work. I've never done anything like this in my career. Most of us never have. And it's a lot of information that got put out, and this work, a tremendous amount was just put back onto the counties as to how we're going to handle this. I was surprised to see that there weren't school districts put into the tier 1 just because they have quantified contacts with children and people from all samples of all households in our community. And I understand where you're coming from with that. It's something that we can look into as far as population numbers, and those are difficult to obtain. It's with breaking these things down, we can use census. It's not always correct, but look at, if we have excess vaccine left over in the tier 2, could we deliver that out to that community if they wanted to come in? And that's something that Marcia and I'd have to talk about. I do rely on her input heavily on this. Her specialty in public health, mine is logistics and managing, time frames and efficiency and things like that. But to be able to put this together, if we have the extra vaccine and it's there, and it's something that as a board we can do, and I can do it legally and ethically, we could look at potentially delivering that out.
Well, I appreciate that approach. I mean, I wouldn't expect anything different from our county, but I'm going to just state for the record, I had an awful lot of folks that are in that high risk group. They've been told from the beginning they're in the high risk group. They're shut-ins. They're folks that have been they've been shopping at 6 o'clock in the morning at grocery stores trying to minimize their exposure and whatnot. And I'm certainly concerned that we're going to deliver a message to those people that are there at the bottom of the list in terms of the vaccination side of it. And I would hope that we could take a look at that because I think it's important.
No, and I very much agree with you. You know, and it's for and putting this together, you know, right now, what we're doing is we're following the guidelines that we're given. The most important thing to me is that we get it here. And, you know, once we get it here, my personal opinion is that we have some leeway, because if the option is, you know, waste of a vaccine versus delivery of the vaccine to somebody in our community to continue to prevent the spread of this, why would we waste it? You know, it's, to me, that's not conservative government use of resources. And I can't see any resource that we received during a declared state of emergency, both with the county and the state, that we wouldn't use that resource to the best of our ability. And this vaccine is a resource. You know, and the plus side with it is too, if we're delivering and it comes out through this, we're delivering you this at no cost, because I know that sometimes financial concerns for some of those folks that you were talking about is an issue as well. Excuse me, there is no bill for folks to come in and receive this vaccine. You know, so it's definitely something that we can explore and look at.
Well, Sean, I think one more comment. I think just a suggestion I'd like to throw out there on the table. If we are anticipating that we may have vaccine that could be wasted, I think it's on us to collect the names of those people, maybe in those high risk groups, and get a list of people and contact numbers so that we can contact people who wish to be vaccinated in tier 2 if that vaccine is made available, and actually get a list of people we can contact and make sure we get them in there.
Mm-hmm. And I agree with that. You know, it's going to be short notice, and that's something like when I was talking with Dr. Jensen about, you know, if we have remaining vaccines left over, and I can't promise that I have enough for all of, say in this case, his employees, because the district is a very large entity, but I will definitely give out whatever I can. So we do need to let them know it's going to be kind of short notice if we're able to do that, because of the 4-day window for the usage of the vaccine. Because once it comes out of that deep cold storage, and I did look into purchasing our own freezer here, those are $13,000 freezers. They're really expensive, and they have a whole list of criteria where it has to be stored and how this works. So it just wasn't something that's necessarily feasible for us as a county. I mean, we can't put it here in our building to do that. So we have a 4-day window. So it's something where, you know, we need to look at the transportation logistics of it, you know, to get these folks into the pod. Maybe we can work with some of our community partners on that, you know, to be able to transport down, but still maintain social distancing guidelines, or if their friends or family are willing to help them out, which actually be ideal for minimizing contacts between people, to get them into the pod. But it's definitely something that we can work on putting together and, you know, see where we're at. With the vaccines on tier 2, the estimates that we have for our county, I'm ordering every one of those vaccines. So I'm not cutting the quantity of vaccine that we receive down. Hopefully if I can get this survey together and get this out, it's going to give me a sample of our community so I can come up with an average of the people that want to receive the vaccine. And that may give us an idea of, you know, what we have on hand that's going to be dedicated to usage versus what we may have left over that we can dedicate to use to bumping down to the next tiers. And I will be honest, I'm the only one in the state that I know of that is doing this. When I proposed it to the state in one of our meetings to bump it down to the school district, I was told it wasn't something they had thought of, but they didn't tell me no. And I haven't gotten a follow-up with it. So I'm just assuming we're okay to do this.
Okay, great. I think that's an item that we probably, this is for Dave Mediola, this is an item that we probably ought to have on our community's COVID summit that we're proposing. That is information that I think people are very much interested in getting some answers to. So I think that'd be a good way to deliver that.
Okay, thank you. Any other questions? Commissioner Chair, you have anything for Captain Wilkin?
I have none, thank you.
Commissioner Bell?
No, for me.
Dr. Stringham?
No, I sure don't. Thank you very much, Sean.
And I'm assuming if the sheriff has a question, he's probably already asked it.
He said he does not.
Okay. All right. Thank you, Captain. Appreciate it. And we'll go to Nicole now with your report, our public information officer. Are you on, Nicole?
Can you hear me?
Yeah, we can. Certainly. Go ahead.
Can you hear me?
Yes, I can hear you, Nicole.
Okay, thank you. So since Thanksgiving Day, we've reported 98 cases to the community. We have actually been notified of a total of 134 cases, but 36 of those have not yet gone through the tracing process, so we'll hopefully clear those today. In November, Humboldt County reported 208 cases to the community. Just to put that in perspective, our previous high month was October with 49 cases. Humboldt County currently has the second highest positivity rate in the state at 36.5%. I am anticipating that that will rise even more dramatically because our total number with the state right now is at 326. It has not been updated. We also are recording the second highest number of cases per 100,000 at 2245. So McDermott seems to be doing pretty well. They are up 3 from 1 week ago. They have 8 active cases. Just so you know, currently as of last night, we have, sorry, I just lost that number. I think we have 130 active cases. Golden Valley Medical Clinic and Ridley's Pharmacy continue to test for COVID-19, and several of the area mines are also working with private companies that are conducting testing. This past Monday was the 3rd week in a row that Humboldt was flagged by the COVID-19 task force for our high case rate and high positivity. That meeting is going on right now, but we are not required to present since the state is on a pause. And as you heard from Leanne, with regard to hospitalizations, 7 Humboldt County residents are currently hospitalized and 5 of those locally, and no ventilators are in use. So it looks like the state is up just shy of 18,000 cases from 1 week ago. The state is averaging about 100,000 tests each week, and the state is up 154 deaths from 1 week ago. As I mentioned, Humboldt currently stands at 408, and we unfortunately are up 2 deaths from last week. We are currently at 6 deaths. Washoe is up 3,000 cases from a week ago, up 39 deaths, and Clark is up just shy of 12,000 cases from 1 week ago, up just shy of 100 deaths from 1 week ago. Lander up 54 cases, no change in their deaths, and Pershing up 7 cases, no change in their deaths. And Elko up 454 cases, which is about what Elko has been doing. They've been averaging about 400 to 500 cases a week. They are up 3 deaths from 2 weeks ago. Over the last week, Nevada has had a lot of record-breaking hospitalizations. Northern Nevada especially has experienced more than a 250% increase over the past 30 days in hospitalizations. And this is kind of an interesting statistic, but in 26 of the past 27 days, Nevada has recorded more than 1,000 cases a day, and actually in the past several weeks that's been closer to 3,000 cases a day. State's positivity rate is now 17.1%. To put that in perspective, the goal is to get to less than 5%. As of Tuesday, statewide hospital occupancy rates are at 78%. ICU units, 65%. That's down from 68%. And ventilators in use at 36%. That's up from 35% 1 week ago. And as you probably heard yesterday afternoon, Governor Steve Sisolak updated the state on the COVID-19 vaccination plan, and we've heard some really great information from Captain Wilkins, so it sounds like we are in good hands. And that's all I have. Thanks.
Thank you, Nicole. We have questions of Nicole. Commissioner Bell? Do you have any questions, Commissioner Bell? No? Commissioner Cherry?
No questions?
Sheriff Allen?
No questions. Thank you, Nicole.
Commissioner French?
Thanks, Nicole. I have no questions either.
And Dr. Stringham?
No, I sure don't. Thank you very much, Nicole, for that presentation.
Thank you, Nicole. Appreciate it.
Mr. Chair.
Yes.
Dave Mendiola. I just have a not necessarily a question, but a comment. Nicole and I have been working on the flyer that was recommended in earlier discussions about how to message better in our community. And so it was circulated out to all of you, and I think we've gotten responses from some of you, but I think that the thing that we're trying to focus on is, rather than talking about doing the right thing, is to make the correlation between, a higher number of cases means the likelihood of potential business closings, school closings, and of course the run on our hospitals, and trying to make that correlation between getting that under control so that we don't have that we have a less likelihood of having closures and things like that. And so we're working on that, and we're trying to get that done and make sure it's a message that makes some sense, and that will go to every single door. So I just wanted to make that comment. I don't know if Nicole, you have anything else to say about that.
I don't.
Thank you.
I think those comments really put it in a nutshell there. We need to try to contact those people that maybe we haven't been able to get to yet to help us with this. And then as we move forward and we can get some sort of a Zoom meeting, I think that can help as well. Okay, we'll go to item 5 now. Update on the city of Winnemucca wastewater testing for COVID-19. Alicia Heiser.
Hello.
Good morning.
So we have received the results from the samples that were taken last week on November 24th. And the cumulative RNA concentration is up slightly from the week before. So those would have been the November 17th samples, but still not nearly as high as we were seeing in early November. The November 3rd and November 10th samples had a much higher cumulative RNA concentration. And the area with the highest concentration from last week's samples was the Malarkey, Harmony, Bridge Street, Mizpah Street area, and we collect that sample actually on Bod Street on the west side of the railroad tracks. And so this area includes the hospital, and it may have a higher concentration this week, or the samples were collected, but results for this week due to the number of patients hospitalized right now. I will say that our wastewater results were correlating very strongly with our cases per day, our peaks in cases per day throughout September and October, and even those first couple of weeks in November. The last couple of weeks, though, we've continued to see a rise in cases per day, but we have not necessarily seen an increase in the viral RNA in the wastewater. And so Dr. Stringham and I have thrown around a few hypotheses, but so far we're not exactly sure why that correlation is not as strong as it used to be. Some of the things that we explored were the difference in the PCR cycle threshold of the wastewater tests versus the swab tests that are being done at the testing facilities. But the cycle thresholds are similar for both. Dr. Stringham asked if the could have an effect on, could it be diluting our sewer system? And that's not the case. Our stormwater system is totally separate from our wastewater system. Our public works crew thought maybe cleaners and disinfectants were killing the virus before we were able to grab the sample, but Dr. Stringham informed me that cleaners and disinfectants typically just dissolve the envelope of the virus, but they don't actually destroy the RNA. So we would still be able to pick up that RNA. And so the two remaining things that may have an effect on this would be cases outside the city limits. I don't have any information about the positive cases other than the information the public has, which is, you know, age, gender, those types of things. So I don't know if we're having a large increase of cases outside the city limits and maybe they're not using the city wastewater system. And then the other thing that I'm still learning about, I actually just learned about it this week. When the wastewater tests the samples are tested, they actually test for two different types of genes that are present in the viral RNA. And throughout the entire testing period, both those numbers, they were called N1 and N2, they came back very similar. But this week there was a large relative difference between N1 and N2. And so I don't know what that means. It's just something that was different this week. And so I'm trying to get some more information from the lab to learn why the two genes or the concentration of the two genes may be different. So I guess that's about all I have as far as updating on the wastewater testing, and I'm certainly willing to answer some questions.
Alicia, wouldn't your wastewater test correlation with the positive test have a different skew to it, where we've gone from the state labs taking 7 to 10 days to Quest now taking a much shorter time?
With the different time frame, we would probably just see a shorter lag in the positive cases per day after the wastewater samples. But really, my wastewater samples have decreased the RNA concentration since the samples taken on November 3rd. But as we all know, our positive cases continue to rise. And so we're not seeing that trend at all. And a shorter time frame would be a shorter lag time. And so, I wouldn't expect that the lag is coming later because we're actually getting those results from Quest faster.
Any other questions for Alicia? Commissioner French?
Thanks, Alicia. I have no further questions.
Commissioner Bell? Commissioner Cherry?
Thank you. I have none.
Sheriff?
No, I have none, but thank you.
Dr. Stringham?
No, excellent presentation. I don't have any questions. Thank you, Alicia.
Hey, thank you, Alicia. I appreciate it.
All right, thanks.
Okay, now we'll move to Humboldt County School District in their report. Who do we have on from the school district today?
Hi, this is Dawn. This is Dawn Hagnes, Humboldt County School District Assistant Superintendent. Can you hear me?
Yes. Thank you, Dawn.
Okay. You're welcome. So I wanted to start first by saying thank you. One being for the City Cares Act money. We were, as you, I believe, know, before we were able to purchase foggers to sanitize our classrooms, sanitize all of our facilities on a very frequent basis, and we know that's making a difference. Right now, it feels like Christmas. We have ordered air purifiers for all of our employees for every space that we have inside our schools. That's thanks to City Cares money. And we've had UPS driving back and forth for the last 2 days, dropping those off here, and we are delivering those as fast as we can. And so we know that's going to make a difference for staff and students moving forward. So we appreciate those supports. While I'm on thank yous, I think the same thing with immunizations. are the vaccinations. It's so nice to hear that we have an opportunity. We know we have an opportunity in tier 2, but to know that there may be remaining vaccinations that were able to be part of tier 1 in some fashion. We sent out that note after 3 o'clock yesterday, and we immediately, as was reported to, we had 80 people sign up. So we know we have interest within our own staff, and those are just the people that happen to have checked their email after work last night. So we are eager to be part of the team being able to be vaccinated. I wanted to give you some numbers. As I reported last week, and you heard the governor speak, he wants school open. He believes our kids need to be in school. Dr. Jensen, myself, our school board feels the same way. We want our kids physically on campus. We know it makes a difference. Not only am I the assistant superintendent, but I have a husband who works as a teacher in our school district. I have 2 kids in school. I know how important physically being on campus is, but I do want to share our numbers. And so when we're talking about people maybe not wanting to test or not wanting to be cautious or being really exhausted and tired of this, or when we hear from people who say, I can't afford to not be at work, the longer term impact is going to be worse if we don't take the proactive approach or the right approach now when it comes to quarantining. Because at some point, we're not going to have employees to be inside our classrooms to be with kids either. So just some of our most recent data, our numbers just from last week, we had 7 staff members test positive last school week for COVID. We had 12 students just last week test positive for COVID-19. Of those 12 students, 8 of them are between 7th and 12th grade students. Of our staff, we currently have 15 active COVID-19 cases, and they are out right now. We have 17 staff members that have recovered. Now, these are numbers as of last week. I can already tell you we're at an increase of about 10 positive cases at this point, and we have a number of them also pending. Humboldt County has about 450 employees across our entire district. As of the first 5 weeks of the school year, we didn't have any cases. We didn't have any quarantines. Prior to November 16th, from that 5-week mark up until November 16th, we had 40 employees who were quarantined, either because they had tested positive or because they were part of a direct contact, either within their household or outside the household. That number since November 16th has more than tripled to 130 people. So we have gone from nothing to 43 weeks ago to 130 people have had to quarantine at some point out of 450 employees. Student-wise, prior to November 16th, we had 172 students out on quarantine, whether that be because they were positive or part of a contact. Since that time, in the last 2.5 weeks, we've had 334 more kids quarantined. We are now at 500 plus quarantines in a very short time. We have 3,000 kids in our school district right now, so you can imagine what that's doing to the education of kids. We have teachers Zooming from their homes. We have aides Zooming classes when they can, as long as they're healthy. We have kids when they're healthy and when they have the access and the capability and support with parents, Zooming into classrooms for instruction when it's possible. But if everybody doesn't do their part to help us, we don't know what's going to happen next. And so we just plead, because we don't want parents to lose jobs either. We don't want parents missing, missing out. But if we don't take the 7-day quarantine or the 14-day quarantine, it's only going to be worse when we are in full closure, which is not what we want. Couple of other things outside of numbers that are just things that we're thinking about, because we also know that the negative approach isn't working. And so I'd like to talk to some leadership groups about maybe some PSAs that we can do on our end. About maybe something like, I wear a mask because. Getting some of our own people to talk about what the impact the virus has had on them personally or their families. For me, I've lost a family member to COVID-19. I've also had a family member in the hospital for 29 days for COVID-19. I know the impact and I see it across our schools. I hear people all the time who talk about, it doesn't matter, I'm a very healthy person, I'll be fine. And I've said that sometimes that's true. We've been very fortunate. Sometimes our very healthiest people don't even know they have it. I've seen other cases where our very healthiest people are the ones that end up in the ER. We've had family members, we've had employees of ours in the hospital, we've had them in the ER. We want to be part of any type of Zoom, Facebook Live, or any other opportunity that there is. We know people are tired, but I think if we take the positive plea, we've done this for 9 months, 3 months more or less. We're so close now. If we just stay strong together, that's going to matter. One of the things we have realized is we've missed a population of our own employees in educating them. And so that's something that we're going to do, just really working on our own materials that we have in English, working on translating them, and then making sure we have some individual department meetings with groups that maybe we haven't done a very good job through emails and Facebook postings. And then finally, we were calling parents every time that there was a case inside a classroom. As you can imagine, with the sheer number of cases recently in the last 2.5 weeks, that isn't even possible. We still have a full commitment to contacting parents when there's a direct contact or any chance of that positive direct contact and need to quarantine. Otherwise, we're going to provide weekly updates with all of our numbers, cases for that week, and then also just our numbers of quarantined and recovered students and staff. We know the importance of the immediacy of rapid testing. We know it makes a difference. We do have some questions because we know this is a struggle. One of the struggles we're facing is some of the places in town, or there's a place in town, we never know what's accurate or not. But if somebody is symptomatic, they've been told they're not going to be tested now, that they just need to go home and quarantine. The problem for us is that matters in the way that if I quarantine for 14 days or 10 days, then my family, if I'm positive, has to quarantine for 24 days. And I can be positive and give it to one of them at the end of my 10th day. And then they go on and continue to be a carrier. If we aren't testing people who are symptomatic and just telling them to quarantine, that extends the time frame or has people back much sooner and just allows the spread to continue. So that's just a concern or a question I have. One of the things we get all the time, and we had heard too, testing was free. And so that's been the message we've been communicating. We want to make sure that our message that we're communicating is accurate and it's the right information. And so one of the things I would love to have is a list. Here are all the places just on a document you can test. Here's going to be the cost. Also, where do people go for a work to return slip? We've encouraged Teladoc, but we have parents who are saying it costs too much to go back and get a work to return. We just want to be able to help spread and communicate accurate information about all of the resources that are available and where they go to for information. one of the places we were told you could go to get work clearance or school clearance was a walk-in clinic. The walk-in clinic has told our people that's not the case. So again, we just want accurate information to be able to share with all of our stakeholders too. And I think that's all I have for now.
Thank you, Don. You brought up a lot of good questions in your comments. And I want to put it out there again. I understand why now the tests are costing $100 through HGA. That was defined earlier in our meeting today, but I also know that there are parents, there are people in our community, they don't have an extra $100. They don't. And what are we doing for those people? What are our policies for getting them tested if they just can't afford it? Dr. Stringham, do you have any answers for the questions that Don brought up?
Yes, I do. First, I think, Don, that was an absolutely fantastic presentation, and it brought up some absolutely outstanding points. The first is that I think that this has been an absolute hardship on so many different people for so many different reasons. It's been very difficult to get accurate information. It's been very difficult to get good compliance. It's been very difficult to get consistent messages and lots of other things. And I think that one of the things I think is that CDC recommendations have changed pretty significantly as we've been doing a lot of this. You brought up a point about the recommendation that people who've been in contact with somebody who's positive no longer be tested. And that actually came from the CDC. It was about 6 to 8 weeks ago. And here in Humboldt County, we initially, when we looked at that, we thought it was preposterous. In fact, the entire state decided that we were not going to use that philosophy for the exact reasons that you'd cited, because it protracts the illness. In the end, it's really what it does. And I think that it's critical for each of us to know what's really going on so that we can make the right decisions. And that's really kind of what's going on. The other issue is in terms of a return to work or school status. We've required that people be seen or at least evaluated by a provider. And the reason is because so many people are symptomatic at the end of the 10-day phase. And a lot of people just prioritize getting back to school or work. And they tend to minimize a lot of the symptoms and give inaccurate information. And I know that when you've worked with us, you were seeing some of the same things that the other team members were too, that in a lot of cases, people, those who are infected or those who are exposed, are oftentimes creating maybe a more advantageous form of reality. They're telling stories and not being accurate in their renditions of what they represent to us. And so in a lot of cases, we have to corroborate this by asking questions to corroborate details. And you can see that all throughout our policy. One of the policies, for example, CDC guideline is that a person can be released from quarantine if they're positive 10 days after they develop the illness. And so day 1 is the day that person develops symptoms. And Humboldt County doesn't do that. We use instead the date of testing. And the reason is because it's a corroborable date. And what we were finding was that a person would have to return to work on a Thursday, and they weren't eligible to return until Saturday. So what they would do is say that their symptoms started a few days before they actually did. And from my standpoint, as a person who officiates contact tracing and a lot of the formal parts of our community response, we've tried to take a lot of the inaccuracies that people introduce into the situations and factor those out. And in the end, what it does is it creates a more conservative approach, but I think it's a better approach. Lots of areas that we could really streamline things, but then the downside, as you know, is that when we do streamline those things, we lose the ability to get accurate versions from the people that we're interviewing. It is a remarkably complicated situation. It really is. And I think you've very eloquently touched on a lot of the frustrations that the rest of us are feeling as you are too. Wonderful presentation.
Okay, thank you, Dr. String. Any other questions of Don, Commissioner French?
Thank you, Don. I have none at this point.
Thank you. Sheriff?
No questions, but thank you, Don.
Commissioner Cherry?
Yes, thank you, Don. Very informative. I don't have any school children, so I have a question in regards to does the school district, you know, earlier on we were talking about how to get information out. Does the school district provide any educational information to the students that they could take home, maybe to their parents and get some of this information out? And if they don't, would that be something that we could look at?
We provided trainings on COVID-19 and best practices for all of our students at the beginning of the year. We then have had materials that we've gone home with families regarding our screening protocols, our expectations for when you quarantine. We've tried to do PSAs on our Facebook pages, and we've sent out scenarios. Right now, we're trying to take the what kind of questions are we seeing and just publish very small pieces. What we've learned is, I think, maybe what we've seen too on Facebook with the lengthy post of cases. What do people look for? They're looking for the most important information at that moment, and typically, what are the number of cases? And so we learned too that chunk it in very small pieces, give a small piece of information and pass that on. And I don't think it always means something to people until it happens to them also. But if other people have resources that we can help disseminate, whether that be on our website or Facebook pages, or also something that we can send out through our mass mailings and emails that we have, we can absolutely do that as well.
Yeah, well, I think that would be a place where, you know, like we've talked, there's a lot of people out there that don't take this seriously. But if maybe the message, if we tweak that message a little bit and say, well, you know, maybe you think you're bulletproof, but you're not thinking about grandma, mom and dad, or someone else that may be compromised. Maybe sometimes when people don't think about themselves, it does ring a bell when you put it in that terms. Well, yeah, if you don't care about yourself, what about so and so? You know, maybe the school would be, because a lot of, you know, our kids believe they're infallible, and maybe that was a good place to get a message out like that.
I think for us, the best message has been when some of our employees or our kids have come back and they've been sick, sadly. I had an employee I was trying to encourage the other day, thought she had a simple cold, just wasn't typical. And I asked if she would please consider testing. And the employee's response was, it's fine, it's a cold. And I said, I just want you to understand that if you come back in a couple of days from what you think is just a cold, the impact you can have within your own family, within your own classroom, and across a school is huge, not including what you can do to the community, unbeknownst to you because you think you have a simple cold. That person tested and was positive. So it's those stories too that are going to matter when we think we have a cold or we think we have a flu and being tested.
Thank you.
Don, I have to agree with you that those stories, and we have many stories throughout the community, not just the school district, but those kind of stories, if we don't go too long with it, would be very important in some sort of a Teams or Zoom meeting. I think they would hit home very hard, and I think the school district could really help out when we decide how we're going to go about this. by sending something home with the students that, you know, we're going to have these Zoom type meetings or Teams type meetings, and that they'll be available at certain times and in a couple of languages.
It does make me wonder, and I apologize, I wasn't going to speak anymore. It does make me wonder maybe about one of our classes putting together a video or a PSA where we take the presentation, but also put in those stories and have that something that could be shared publicly.
Good idea. Any other questions? Commissioner Bell? If you're on, I can't hear you, Commissioner Bell.
Mr. Chair, I don't think he's on anymore.
Okay, thank you. Okay, thank you, Don. Very good, informative update from the school district. I appreciate it.
Thank you. Can I ask one more thing, and I apologize?
Absolutely.
We're coming into a season where we know people are going to be traveling. It's typical in our school community that we have families that will leave for 2, 3, 4 weeks and go to Mexico. Is the county or the state, I believe the state already does, but does the county require any type of quarantine for out of state, but then also out of country?
Hello, this is Abel Darrell-Nav, Assistant County Manager, HR Director. So yes, if an employee does go out of country, our guidance is to require them to quarantine for the applicable amount of time.
Thank
But
you.
that is for county employees, or is that a state?
We're following the CDC guidance for quarantining, Commissioner Tipton. So when an employee gives me a call and, asks, what do I do? I want to go out of the country for vacation. Well, we let them know. If you're able to work from home, then great. You're able to continue as normal. We don't have to do any paperwork for you. You just work from home during those 14 days. But if they can't work from home, then we work with them to get them the necessary paperwork so that they're compensated via the emergency paid sick leave as part of the Family First Coronavirus Relief Act funding.
Right, but I don't think there's been anything pushed out by Humboldt County or the Humboldt County Health Board for the general population that I think Don is referring to, for teachers or students students and family members that go to Mexico, let's say during Christmas and come back.
I believe that's the case. I was just speaking for the county and what our policy is.
Right.
Yeah, you're right, Commissioner Tipton. That was early on. That was recommendations by CDC. We have kept that within the county and make that a county policy. And to me, I would highly recommend that for everybody.
Thank you. And that's what I think we've talked about, realizing the season that we're coming into. It's the first time it's come to us, preparing for it. So I think that's where we'll be moving as well.
Thank you. Okay, thank you, Don. We'll move on now to item 8, approval of a high-risk mitigation plan. Consideration, discussion, of possible action to prepare and approve a plan to mitigate the county status of the high-risk county for COVID-19. County Manager Mendiola, you want to speak on this? Would you please?
Yes, thank you, Mr. Chair. Dave Mendiola, County Manager. So this week, you heard Nicole say earlier that the jurisdictional meeting is in progress right now. However, they have given us a pass this week. So we are not presenting our report to the state this week. However, I think I told you last week that the major changes that we've made is we put some information within the enforcement area of the report that is required, and also our messaging, specifically the flyer out to the homes, and coming up with new ways to do that. We will add to that this idea of putting together a Zoom meeting for the community as a whole, as another way of messaging and getting the word out to folks. So other than that, we will probably be reporting some vaccination plans and that type of thing, which of course is the next item up here. Well, it's more related to the educational process, but so that's what I have to report on that. There's no need for you to approve that at this time. We'll make some updates and bring it back to you.
All right, thank you. Okay, we'll move on to, did we have a question on that? No, okay. We'll move on to item 9 then, vaccination education plan, consideration, discussion, and possible action regarding a plan to educate the public about vaccination and the importance of getting vaccinated.
So, Mr. Chair, Dave Mendiola, County Manager. This was one that was recommended as a future agenda item, and so I think the reason for having it here is to have a general discussion today. You heard quite a bit today about the vaccination rollout. We've heard about the details of the importance of the vaccination from Dr. Stringham, and then of course the rollout from Captain Wilkin. So this is something that I really think needs to be part of the city county-wide meeting that we would have, the virtual meeting that could be covered, and to have the doctors talk specifically about the efficacy of the vaccination, why it is what it is, much like we heard today, and why it's effective, and that type of thing. So I don't know if the doctor has any further comments on that or not.
Oh, thank you very much, Mr. Mendiola. I think that it would be wonderful to talk more about that, and my conception would be to probably visit it during the ongoing community meetings program that we put together, and so we can answer questions, and everybody's going to have slightly different questions. I just want to be able to make sure that we can do it in real time and have people actually be able to interact with us and have their questions answered specifically. And I think it'll really help with buy-in and be a great thing. I think that would be a wonderful time to be able to address things like that.
Okay, any questions on the vaccination education, or any comments that we haven't brought up already? Commissioner Cherry.
No, I think we covered a lot, and it was a good meeting.
Okay, thank you. Commissioner French.
Thanks, Chairman Tipton. I had one question and a comment I need to make for the record on this meeting. I believe that placing the 65 and older group in the tier 3, I think is a weak point in the plan. I think they are a high risk group, and I believe they probably represent the highest probability for additional mortality, as well as run on our healthcare facilities. And from that standpoint, with the HIPAA laws the way they stand, I see no way for us to contact those 65 and over with comorbidities, which have historically added to their probability for a bad outcome. And I think with that being said, I think it is incumbent on us to come up with some way to create a qualified registry for those people to be able to get their vaccinations in a timely manner. And I believe also that that very group of people, 65 and over, are historically the most isolated in our community with regard to communications. So I think we owe it to that group of people that we make sure that they are separated. I know that those folks that are in managed care, I think it's very important for them, obviously, in that environment. But I also believe if you look at the statistics of those people who have been sick in this county, who've developed COVID, and who have and those who have had a significant morbidity or issues with morbidity have been over 65 years old. And I think we need we need to definitely make it a point that those people don't fall through the cracks, and that they are on the front side of it. And I thank you for that.
Mr. Chairman, I'd like to make a comment if I could. Commissioner French, I wholeheartedly agree with what you said. And I have to be honest and say that I'm really surprised that the decision-making matrix for the various tiers looks the way it does. I know that no matter what iteration is brought forward, there are always going to be concerns and different ways to look at things. But I agree. I think that it's a strange juxtaposition in the way that we're doing things in our country. England, for example, has elderly people. The oldest of all their citizens are vaccinated first in tier 1, and yet we're kind of approaching this the way we are. I think that maybe we can have a separate dialogue about this, and I'd like to probably reach out to Captain Wilkin to find out how much malleability there is in this program, whether there's certain things that can be left up to local judgment. I don't know what that looks like, but I wonder if we may be able to change things just a little bit. To be honest, I think that to have elderly people vaccinated after clerks at various stores seems unusual, especially because we've already talked about the fact that stores don't seem to be a place where people are getting this because of other processes that we've put in place that are working very well. So I agree. I think we should revisit that.
Okay, thank you. Sheriff, do you have any comment on the vaccination?
You know, the only thing I want to add is I know that Captain Wilkins said he would look into that. I don't think he's on anymore. He had another engagement. So we will definitely take a look at that and get back with you guys as soon as we get an answer when we talk to the state on some of their conference calls. And other than that, I have no other questions.
Thank you. Okay, then we will move on to item 10, which is a future agenda items, next meeting date. And I would think our next meeting date would be next Thursday at 9 o'clock, December 10th. And anybody have a problem with that date? What about future agenda items? Looks like we've got if we keep our agenda the same way we have it, I think that works pretty well.
Commissioner Tipton, this is Commissioner French. I have one item I'd like at least maybe include in one of our standing items. That has to do with this conversation we're having to do with the hierarchy for those senior citizens in our community. I would like that we could have a debate or a discussion as to what are the compelling reasons to put those people at the bottom of the list as opposed to close to the top of the list, and if it's necessary for a resolution or position out of this county back to the state with those arguments, I would entertain that we include that in agenda.
I have recorded that, Mr. Chair.
Okay, thank you. Is there anything else? I have a question on this agenda. I think we probably should talk about it. Maybe we should have, it seems like we always run into trouble on it. Maybe we should have a hospital report on the agenda right after Dr. Stringham. And that way they can get on with their business of the day. It seems like that's always a problem.
I can change that pretty easily.
I think we could handle that. Okay, any other questions on the meeting date or agenda items? Hearing none, we'll go to item 11, which is public comment. This is the time the general public can comment on any item that they wish to comment on. The public has the opportunity to address the board on any matter not appearing on this agenda. However, no action may be taken on the matter until it's raised, until the matter itself has been specifically included on the agenda as an item upon which action may be taken. So if you have a public comment now's the time, *6 to unmute yourself, and then identify yourself. We'll take public comment at this time.
This is Patricia Tyndall, and I have a couple questions. So my first one, thank you very much from the school district, by the way. And this is a question on quarantine, and I think it should go maybe to Dr. Stringham. We are, so the senior center has been referred by the hospital to bring meals to people that are COVID positive. And we have been bringing meals to them. We've set up a separate route. At what point in time do we believe the patient or the client that they feel fine now and they're no longer quarantining, or their date is up or whatever? How do we decide it's safe to move them to just the regular delivery instead of the quarantining where we take extra precautions? We don't want any of our drivers to be in any kind of contact, because then they go off later on and contact 50 other people with the meals that day. So how do we know when to take somebody off of this COVID quarantine when we're delivering meals and put them on the regular meals program?
You know, Patricia, I really like the question because it gives me an opportunity to bring something up that I think really needs to be said. The simple answer to your question is 10 days after the time that a person developed symptoms, they are no longer infectious in most cases, and 10 days. Formally, we keep people in quarantine 10 days after the date of test because that's a corroborable date. And so that's the formal answer. But what I would tell you is, from my perspective, I would continue to use very, very strict precautions, even once that person is no longer formally on a quarantine program. And that's really the point that I want to make here. Once a person is not formally quarantined anymore, you would still safely never have a situation where an employee got within 6 feet of a customer or of a client. You would also never have a situation where a person who works for Senior Center delivering meals would ever be unmasked, and the client would absolutely have to be masked also. And so there's a difference in terms of the way that we conduct ourselves and the nomenclature that we use. But even in the event that a person still was infectious after that 10-day quarantine was over, if technique is being done the right way, your employee would still not be able to get infected. So I can't emphasize enough that when a person is no longer known to be infectious, that we still treat everybody as if they have this infection.
Thank you for that. And I will assure you that all of my drivers, everybody in our office, all of my staff is wearing hairnets, masks, shields. We have shields between people. We're not 6 feet close. And we are using delivery methods where we never come in contact with the client. So we have a separate route that is those referrals from the hospital that are positive. And I just wanted to know when we can move them to the regular route. So that's number one. Number two, my question is, I understand that home healthcare workers are considered on the tier 1 for the vaccine. And there's 358 vaccines coming here or whatever. How do people get on that tier one, we work with a lot of home health care practitioners or whatever. Is there a letter that goes out? Does somebody get alerted? Where are you willing to get the vaccine? So that's question number 2. And then just a comment for Commissioner French, who was talking about how do you find out about people that are 65 with comorbidities and HIPAA. We are doing meals to people that are over the age of 60. Are medically, I could, anytime we do anything with these people, we need to get their permission first. But that would put out to these people information that says there's a possibility of getting you on the vaccination list. Are you willing to let us give your name and address to the county? So I'd be happy to work with you on starting that list. Please know that is only within our delivery capabilities. Other are being taken care of, home health workers, so we might need to work with them. But there might, we can work together to start your lend, and that's all.
Excellent.
Thank you, Patricia.
I may be able to answer the kind of the first part of the question. So you had asked about the vaccination. I think the sheriff's office is probably the best agency to answer the question specifically about roster and how a person goes about going onto a list. I know that Captain Wilkins worked very hard on that, and he had come up with a total list of all tier 1 folks, and there was a number that he'd mentioned. I thought the number was approximately 741, but I think that number had gone up slightly today. And so I presumably he already has that list, but you might talk to him and ask if there are specific concerns that you've got.
Hi, this is Sheriff Allen. Yeah, you're right, Dr. Stringham. The number's actually 700, and I think it's 758, maybe even 760 now. But what happens is the state provides us the guidance that they want us to follow on the tier 1 and tier 2 list. So we'll go back through that list. I don't have it with me right now, or at least the people who are eligible to be in each tier. So if we can reach it back out to you, Patty, once we get Captain Wilkin back here and discuss that with him. Like I say, I don't think he's on anymore. He had another appointment and he left to that.
Okay, these are all very good questions. Yeah. Some of them that we can't answer today, maybe we can get answered in a public meeting, so Zoom meeting or whatnot. Any other public comment?
This is Dawn Hagnes. I have just one more I forgot that I had on my list.
Okay.
And this is, oh, of course I'm going to forget it. Oh, for people who we know are to be in quarantine, whether they're our employees, there are students, or just community members, is there something that Humboldt County, I know that the governor has spoken about this topic a little bit, but is there something that we should be doing when we know people are still in quarantine? And they're not?
I don't think, who wants to answer that?
Maybe it's not a question to be answered, but it is a concern that I obviously have when we have people running around in the community. And again, it comes back to potentially taking it serious, but it's difficult.
Don, Dave Mendiola, what was the question again? I was kind of multitask here and I missed
it. The question I have, or the concern I have, is the number of people who are to be on quarantine, and whether it's because they're positive or because they're a direct contact, but are still running around town. as if they're on vacation and getting their Christmas shopping done, still working out, all of the things that maybe they would do that shouldn't be happening while they're on quarantine.
I may be able to answer that question best. In the early days, before we had a tremendous number of cases, it was easier for the FAST team and some of the folks in community paramedicine at the hospital to reach out to those folks. And we were actually doing quite a number of different things, responding to questions and assisting them and doing things in order to make sure that we could facilitate people staying in their quarantines. With the number of cases that we have at this point, we haven't been able to do that on a ready basis the way we had early during the pandemic. But at this point, we'll have more members of the FAST team and a modified administration that I think will be able to address some of those things. I had not specifically known that that was still going on also. And so we know that there are people who sometimes in the past have skipped out on their quarantine orders. And in each case, when I've become aware of that, I've either made contact with those folks myself or had a representative make contact with them. And but I hadn't known that that was still going on. So certainly, Dawn, for you and for anybody else who may have know of any cases like this, may know of any cases like this, please reach out to me here at the office or by text, any method, to let me know that there's a person who you suspect may be the subject of a quarantine order who's out at large. And if that's the case, then we will absolutely make contact with that person. There's a provision under NRS 441 that gives me the capacity to a specific legal order against that person, but they have to actually be infectious in order to have reason to believe that they're infectious. If the person is merely on a quarantine for an exposure, but is not yet known to be infectious, it's a little bit less clear. But please, definitely anybody who has knowledge of a case of this nature, please reach out to me, let me know, and we will immediately respond. And the responses in the past have been pretty vigorous, and we take these types of things very seriously, as you know.
Thank you. I appreciate that.
Thank you.
No, I would just, this Sheriff Allen, I'd just like to add something on that. And I do think that that is the best approach. However, we're not, meaning law enforcement is not privileged to anybody who comes back positive or has been ordered to be under quarantine. So it would be up to somebody who would know to contact Dr. Stringham that that person is supposed to be under quarantine, because that is not public information.
We may have lost Commissioner Tipton here. I don't know.
I don't see him on the list of attendees anymore.
Yeah, he might have dropped off here just by accident. He's had issues like that before. Yeah, so I guess what we probably ought to do, is there any more public comment? I'm sure he's trying to get back on. So any more public comment?
This is not a public comment, but I just wanted to remind everyone that the crisis counselors are still here offering our counseling services, and now our translating services. So I think it was Patricia who said she might be needing a translator. And I'm pretty sure Abel is also bilingual, but if he needs help with that future Zoom meeting you guys want to do for the community, I'm more than happy to help you guys. If you guys know of any seniors, I know they've been hit the hardest just because they haven't been out of isolation. I am willing to travel to Winnemucca. I will give you guys my email if you have any further questions or concerns, and it is gcanales@health.nv.gov, and my cell phone number is 775-431-7087.
Thanks, Giselle. Appreciate that very much. Could you just repeat that email address one more time?
Yes, of course. The email address is gcanales, CANALES @health.nv.gov.
Thank you very much. I just like hearing you say it.
No problem.
Hey, okay, so any other public comment? Hearing none, we will adjourn this meeting at 12:06 p.m. Thank you, everybody, for your participation. We do appreciate it.